Good morning, ladies and gentlemen. My name is Councillor John Robinson. I'm the Chairman of the Adult Wellbeing and Health Overview Scrutiny Committee. May I welcome everybody to Durham County Council's meeting and the first meeting virtual of this committee. This meeting is taking place on Tuesday the 7th of July and is being recorded live onto the Council's website, and it will be available to be viewed from the public from a minimum of 6 months. May I give a warm welcome to members, officers and any members of the public or media who are watching the live feed of the meeting. Please bear with us as this is our first virtual scrutiny committee. Before I commence the formal business on the agenda, I would like to cover some of the housekeeping issues for us all to know in order for the meeting to run as efficiently as possible. For those participating in the meeting, please remember 1. All participants except the chair must mute their microphone. All participants to blur their background wherever possible. Could you speak using the chat function on the right hand side and type in RTS, right to speak. Remember, everyone in the meeting can see your message. When invited by myself, remember to unmute your microphone. Once invited to speak, please introduce yourself with your name and position, unless you've already done so earlier in the meeting. If the chair's connection, my connection, is lost, Councillor Rob Crute, Chairman of the Overview Scrutiny Management Board, will take over until my connection is restored. If members have any issues with connectivity, try switching off your video and use the telephone function. And if connective issues continue, you may have to leave the meeting and rejoin to get a better signal. Ladies and gentlemen, I and the rest of this committee recognise this has been a very challenging time for our communities, and we wish to express condolences to the many families in the County Durham and indeed the wider United Kingdom and world who've lost loved ones and have been affected by the COVID-19 pandemic. I know the members of Durham County Council would like to join in with me for 1 minute silence in memory of those poor souls of the County of Durham who lost their lives during this pandemic. So, ladies and gentlemen, please may we have a minute's silence. Thank you, ladies and gentlemen. Before starting the formal agenda, I would like to welcome on your behalf and introduce a number of additional key officers and supporting today's meeting from Durham County Council, County Durham and Darlington NHS Foundation Trust, NHS County Durham CCG, Tuve NHS Foundation Trust, NIAS County Durham Care Partnership. May I begin by welcoming Councillor Mrs Lucy Hovels, Cabinet Member for Health, and thank her for all the advice and support she has given this committee during the pandemic. Welcome Jane Robinson, Corporate Director for Adult and Health Services, Durham County Councillor, Amanda Healy, the Director of Public Health, Lee Alexander, Head of Adult Care, Jenny Howarth, Head of Strategy, Michael Fleming, Strategic Manager, Research and Public Health Intelligence, Durham County Council, Rachel Rooney, the Commissioning and Development Manager for NHS County Durham, Joseph Tandy, Director of Primary Care, NHS County Durham, Mrs Sue Jakes, hello Sue, Chief Exec of County Durham and Darlington NHS Foundation Trust, Gillian Curry, Head of Communications and Charity, County Durham and Darlington NHS Trust, Jennifer Riddingworth, Director of Operations, Durham and Darlington Tuve, Sarah Burns, Head of Integrated Commissioning, County Durham Integrated Community Care Partnership, Malcolm Walker, Acting Director of Integrated Community Services, County Durham Integrated Community Care Partnership, Mark Cotton, the Assistant Director for Communications and Engagements, NIAS. Ladies and gentlemen, welcome to this morning's meeting. I hope you enjoy doing a meeting virtual, and maybe one of you may end up being the next star of Gogglebox. So, if we now move to our agenda, we are being supported as ever by our colleagues Jackie Graham and Steve Gwillan, and Amanda is taking the minutes. So first of all, could we ask for any apologies, Jackie?
Thank you, Chair. We've got apologies from Councillors Ling, Jopling and Reid.
Thank you. And any substitute members?
There are no substitute members, Chair.
The minutes of the meeting held on the 5th of March. Can I hand over to Stephen?
Thank you, Chair. Before inviting members of the committee to approve the minutes, there are a couple of slight alterations to propose which have been brought to our attention by Councillor Temple. I refer directly to minute number 7, which was the Health Protection Assurance Report 2018-19, and specifically page 9, and suggesting a new paragraph after paragraph 4, which begins with Councillor Beatty's name. The proposed addition is as follows, Chair. Councillor Temple referenced the potential impact of coronavirus on the elderly and infirm and sought assurance that guidance would be provided to care homes and social care providers in respect of the virus, especially in respect of those services that were commissioned from the sector by the County Council. That's the first amendment, Chair. The second one relates to the very last paragraph on page 9, where it reflects a member of the public introducing himself. What I would say, Chair, is that that member of the public actually introduced himself as a local GP. So I think for accuracy that needs to be reflected in those minutes. So with those two amendments, Chair, members are invited to agree those minutes. Thank you.
Thank you, Stephen. Do we have a proposer for the minutes?
Yes, you do, Chair. It's Councillor Ted Henderson here, the Councillor for Barnard Castle West, and I propose that we accept them.
Thank you, Councillor. Thanks, Ted. Do we have a seconder?
Yes, I'm Councillor Pauline Craythorne for West Comfort and Bishop Midland. I second the minutes, Chair.
Thank you, Councillor Craythorne, Pauline. Can we agree? Good, thank you. Stephen, would you like to deal with matters arising?
Thank you, Chair. To date, I have no matters arising that have been brought to our attention, Chairman. So with those amendments, Chair, the minutes are agreed.
Thank you. Any declarations of interest? If not, we then move on to items from co-opted members. We've got non-registered, but can we welcome David to your first meeting? I hope you enjoy it and we see you on a regular basis. David from Health Watch. So therefore we move on now to item 6. We're going to deal with item 6 in 2 distinct reports and 2 distinct parts. So if members could make, for 6A, their questions targeted to the part 6A report, and we expect the majority questions on 6B. So therefore, can we move over and welcome Amanda Healy, the Director of Public Health. Amanda, please could you present your report?
Thank you, Chair, and good morning, members. I'm delighted to be here this morning to provide an update on the public health overview in relation to the planning and response to COVID, and then we'll pass over to Lee Alexander and Sarah Burns for the second part of this morning's reporting. This report builds on obviously the verbal update that was given at the Scrutiny meeting on the 5th of March as part of the overall Health Protection Assurance Report. And I think we have to say that obviously the scale and reach of COVID has been unprecedented. I've worked through other major epidemics such as Ebola and pandemic flu, and nothing has affected lives as much as COVID-19. You'll also hear throughout the report, I'll stop to ask Michael Fleming, the Strategic Manager for Public Health and Intelligence, to give an update on some of our data and intelligence. However, I think we're all aware that every statistic has actually got one of our local residents and families sitting behind that and affected by COVID. There is a lot of detail in this report and a lot more detail that sits behind, and obviously members, you may want myself or colleagues to come back and provide more detail and information on certain elements of the report at a future scrutiny meeting, and we'll obviously be more than happy to do that. I think we also need to remember that although the virus was identified in late December in Wuhan in China, is highly infectious, it is still fairly new and we are still learning a lot about the virus, and there is still no vaccine as yet or no cure. The report begins to outline obviously that at the end of January a public health emergency was called, and on the 11th of March WHO, the World Health Organization, outlined that this was a pandemic. What we've aimed to do from the onset of the report of the pandemic is to try and communicate clearly and transparently with members and obviously with our local communities, and to share data about the virus as we've learned it through the response and obviously into the recovery and living with COVID. We know that data and the intelligence presents many challenges to us, and Michael will go through shortly some of those challenges, but will also outline our position in relation to County Durham and how we've compared to other local authorities across the country. We know that from small numbers of data can be very unreliable. We know that our access to data has been very challenging at times, and we've only recently received access to some of the testing data, which helps us to inform our response. We also challenge that understandably people want to know so much about coronavirus, and we did set up an email account for different queries that's responded to almost 650 queries. And we also know that numbers can be challenging, and we use rates wherever possible so that we can compare with other areas. Paragraph 25 really starts to kind of outline those different, from a global level right down to a local level, our kind of key dashboards and the numbers and the statistics. And I'm going to hand over to Michael Fleming, who will give a brief update on those statistics from global down to local level, and then I'll talk us through the rest of the report. So, Chair, that's okay. I will hand over to Michael to take us through some of the key points in relation to the intelligence that we have had from the beginning to what we have to date. So, Michael, if I can hand over to you, please, that would be really helpful.
Thanks, Amanda. Good morning, Chair. Good morning, everybody. My name is Michael Fleming. I'm the Strategic Manager for Research and Intelligence here at Durham County Council. I'm going to give a brief verbal overview of the pandemic globally, nationally and locally. And in terms of the local picture, you should have all seen, hopefully, and to have direct access to our updated weekly member dashboard that is available on Durham Insight, that we've created to keep members across County Durham and Darlington appraised of the latest publicly available data. The link is in the paper. In terms of the global figures, reported to the World Health Organization, as of the 6th of July, there were over 11,300,000 confirmed cases of COVID-19 and included 531,806 deaths. In terms of the UK picture, this is available by the PHE dashboard. The total number of lab confirmed cases as of yesterday was 285,416 positive test results. The daily number of lab confirmed UK cases was 516. There were additional cases added on Sunday, the 5th of July. The total number of COVID-19 associated UK deaths currently stands at 44,220. They are the deaths of people who have had a positive test result. The daily number of COVID-19 associated UK deaths as of added on Sunday was 22. So just to point that the number of lab confirmed positive cases via the PHE dashboard, which covers national, regional and local authority level, now include those identified by testing in all settings. So that's Pillar 1 and Pillar 2. Due to this change, many cases previously not attributed to any area are now included in our local authority totals. This isn't a surge in recent cases. It's now more accurate reporting. So just quickly to move on to the situation for County Durham. In terms of cases, as of yesterday, there were 3,303 cases in County Durham, positive lab confirmed cases, at a rate of 626.8 per 100,000 population. This ranks County Durham as the 25th highest of 150 upper tier local authorities. Just to give you a very quick sort of split in terms of how that's been progressing over time, we've had no additional cases reported through Pillar 1 and Pillar 2 for 1 day or 3 days, and over 7 days we've had 6 additional cases. At 14 days there's been 33 cases, and on 30 days 119. So in total 3,303 positive cases at a rate of 628.8 per 100,000. So just moving quickly on to deaths, unfortunately, we have seen 684 COVID-19 related deaths in County Durham up to the week ending June the 19th. This is at a rate per 100,000 of 629.9, compared to 463 per 100,000 in England and 525.5 in the North East. This is statistically significantly higher than England and the North East, and the rate is the 3rd highest per 100,000 in the North East and statistically significantly higher than 4 other local authorities in the North East. Peak COVID-19 deaths occurred in week 15 with 98 confirmed deaths. And that has reduced to the most recent available data, which was week 25, which was the week ending June the 19th. That was down to 4 COVID-related deaths in County Durham. From the start of the pandemic, we created a local death surveillance system across County Durham and Darlington, working very closely with our registrars in both local authorities, who've been very diligent in terms of recording of COVID-19. So basically, where there is any suggestion of COVID-19 on the death certification process, those deaths are being marked down as COVID related. This is borne out by how our numbers in our local surveillance system match what is produced by ONS about 11 days later. So just in terms of the setting split, over the pandemic period, there have been 305 COVID-19 related deaths in hospital. That's 44.6% of all COVID-19 deaths in County Durham. Care homes have experienced 353 COVID-19 related deaths in the same period. That's 51.6%. This is the highest number of COVID-19 related care home deaths in England, but not the highest rate per 1,000 beds. Peak care home deaths occurred in the week commencing the 10th of April, which is week 16, with 49 deaths. The latest is the week commencing the 19th of June, week 25, where we experienced 4 deaths in care homes. Our rate per 1,000 care home beds is 67.2 compared to 30.8 in England and 46.4 in the North East. This is statistically significantly higher than England and the North East, and we're ranked the 9th highest of care home related deaths, care home COVID-19 related deaths nationally. And that's the highest rate in the North East. It's statistically significantly higher than 9 local authorities in the North East, but similar to South Tyneside and Newcastle. Deaths are also reported at a small area geography by ONS, made available via the ONS website. These counts by ward are significantly skewed by our care home deaths, as 51% of COVID-19 deaths have been seen in care homes locally. We're unable to calculate a rate per 100,000 based on these numbers, as the numbers are at a small area level relatively small. Overall, the mortality experience in County Durham is complex. We have further in-depth analysis which is available should members require it.
Thank you, Michael. And obviously, in terms of some of our response, that will be covered in the second part of this report, particularly by Sarah and Lee, in terms of the service response and how we've worked with certainly our local communities, and particularly, obviously, as Michael's highlighted, both the hospitals and obviously the care home situation. That will be covered in more depth in the second report. But thank you, Michael, for that. And obviously the dashboards that are in that report, our report will are updated on an ongoing basis, so members can access them on an ongoing basis. Just to then start to kind of bring the overall kind of public health response and how we've worked nationally and regionally and locally, paragraph 26 to 37 in the report outlines the national response, and obviously we have had a very centralised response in relation to the pandemic. In the initial phase, we worked very closely with Public Health England, and they were very proactive in actually carrying out the detection of people potentially with COVID and contact tracing. However, that was stopped in early March, on the 11th of March, as we moved into the next phase of the pandemic, and no longer took place. From the 3rd of March, the government produced their coronavirus action plan. The 12th of March, their stay-at-home guidance, and from the 23rd of March, we were as a nation in lockdown, and the restrictions that applied to go with that. Government guidance has been produced on a daily basis following announcements, and we followed that guidance and implemented it and locally, and also worked collectively at a regional level on key parts of that guidance. On 11th of May, the government produced their kind of rebuild and recover document, and obviously from the 4th of July, many of the restrictions have been lifted. I think what we've seen throughout from a national and what's really emerged are real key health inequality issues. A lot of focus on our minority ethnic communities, but also clear inequalities in relation to deprivation and age as well. And we've seen this borne out in our local figures. From paragraph 38 to 46, the regional response to public health is outlined, and certainly at the Scrutiny Committee in March, both myself and colleagues from the NHS outlined the work that was starting to take place at that point in time, aligned to the North East Pandemic Flu Framework, which included coronavirus as an appendix. And we obviously have worked with that, but then very much have taken the direction that has come down from the national level, and planning assumptions that were given to us from a national level. On the 25th of March, a major incident was declared by our local resilience forum, and that covers both County Durham and Darlington, and that was stood up. The Director of Public Health, myself, and the Director of Public Health from Darlington have attended every single local resilience forum to provide public health and advice, along with partners across County Durham, and a range of calls. I also chair the North East Association of Directors of Public Health, and have taken an active role in seeking to raise concerns with government, including testing and response to that, and access to data, and also in relation to outbreak management. So a very strong input, I think, at a North East level, both from a public health perspective, but also from colleagues, which you will hear about soon. In relation to our really, really important local response, paragraphs 47 to 67 outline the response that we took from a public health approach in relation to the planning and response. What we aimed to do was ensure that there was public health advice in all of our planning and response groups, both across the council and working with partners. Michael's outlined some of the intelligence and the data that we've used to guide us, and we've aimed to produce that on a daily basis where possible, and to provide that both to the public through Durham Insight, and obviously also to try and keep members up to date. That the first briefing locally was provided to members on the 23rd of January, and that has continued with very close collaboration with the Communications Department. We also liaised very closely with Public Health England in that early phase when we were trying to detect cases, particularly with our local university that had a lot of students that had actually returned from Wuhan and from China, and to enable us to detect and support pathways of care if anyone was actually affected or infected with COVID-19. We also, and you'll hear a lot more from the mental health service response, but we also have taken a very proactive mental health focus throughout this pandemic, ensuring that people's mental health and well-being is supported. Paragraph 68 outlines our approach from a population health management support to support the community response to the shielded population. We know in County Durham there's been a huge community coalition that has supported people who needed to self-isolate, who may have been isolated and living on their own when we went into restrictions. However, what we did in County Durham, as well as our support to the 25,000 local residents who needed to be shielded, was that we used a population health management approach to identify those that may have multiple vulnerabilities, which took our numbers into over 67,000 people who have been kind of contacted and reached both through existing services to ensure that not only those who are at risk from the virus, but who may be at risk from impact of the virus were supported during this phase. Well, Sarah and Lee will provide more information on the health and care response, but during this period from a public health service response, we've had a lot of services, our commission services that have adapted. We've introduced a new stop smoking service, new No to 19. Our sexual health service became to online, and a lot of support for our drug and alcohol clients at particular risk. In addition, we've put additional support into our suicide and the prevention of suicide and postvention support. Paragraph 79 to 87 outlines testing and the local testing arrangements, and obviously the national approach to this through the national testing strategy. The government, as I've already outlined, stopped detecting cases in March and then introduced their testing strategy. Very locally, there was a really proactive approach to testing carried out in collaboration with County Durham Darlington Foundation Trust, particularly aimed at obviously staff and then our care homes. However, then there was a range of different national measures, including whole care home testing, mobile testing units, and a range of portals that opened up in May. So we've been working both locally and nationally, and this has some of the concerns about this have been raised, and Councillor Hovels, as portfolio holder for Adults and Health Service, wrote directly to the Secretary of State for Health and Social Care, expressing some of our concerns in early May. And that has also been carried out by the Association of Directors of Public Health and the Association of Directors of Adult Social Care. We see now in paragraph 88 as we move towards recovery, and in reality this is a really living with COVID and this is a recovery, and a major piece of work is underway to look at the health impacts of COVID, and a key number of partners are involved in and a community involvement in the production of our health impact assessment, which will result in several recommendations to really think about how the impact of COVID can be mitigated against. And obviously members may want to see the outcome of that health impact assessment. We also, at the very beginning of June, were asked to produce a local outbreak control plan. On the 28th of May, the government launched their Test and Trace service, which consists of an NHS arm and the establishment of a joint biosecurity centre, and also has our local working arrangements with Public Health England Health Protection Team. That local outbreak control plan has been published and will be formally presented to the Health and Wellbeing Board next week, the 14th of July. And again, obviously this document and the work that is taking place in terms of our local outbreak management may be an item that Scrutiny may want to call back in. There are key themes in our local outbreak control plan, continuing with the prevention work that has taken place throughout the pandemic, and also a focus on key themes, continued work with our care homes, our schools, some of our community settings, and obviously the key aim of the local outbreak control plan is to detect and to slow that transmission. I guess because in conclusion, this has been the most challenging threat to health and wellbeing our residents have faced in a generation. I know that the public health team have worked tirelessly along with all of colleagues to really support the planning, response and recovery to the pandemic. And we have seen key inequalities highlighted that we'll be seeking to mitigate against, working closely with our local communities. And as we continue to live with COVID until a vaccine is sought. We must do that with and build confidence in our local communities. So, Chair, I would like to end my input to the report there and pass over to Sarah and Lee to take members through the health and care system response to the pandemic.
Thank you, Amanda. Thank you, Michael. Before we open up, it was a case of when this next bit, when do we did it? When either before your report or before the next one. So I decided to pitch it in between. I've spoken to a lot of our members, not only of this committee, but of the authority, and each and every one of us would like recording, Amanda, and placing in their minutes the members' thanks to the community and the community groups across the whole of Durham who've responded so well to save and protect their community. We would also like to place on record our thanks to the National Health Service, to County Durham and Durham Foundation, to the Tube and other hospital services for the sterling work they did to protect the public, and wish them well in their 72nd birthday week. We wish to say thank you to the care home staff, to the care services and adult care of Durham, because they have done their part in ensuring safety. To the emergency services, the fire, the police, to thank them. We wish to thank especially the NEAS, the ambulance service, for the work they did. To the schools, which whilst they're not part of our committee, Councillor Smith, I know, will thank the schools for remaining open to protect our, particularly the people who had to go to work. And we'd also like to place on record our thanks to all the support teams, the post office, the delivery people, the shops who have kept the community going. So I know the members of County Durham would like to place on record them thanks. So now can I move over to Councillor Mr. Richard Bell, followed by Councillor Mr. Temple. Richard.
Thank you, Chair. Councillor Richard Bell, Barnard Castle West, fully endorse all those thanks, and particularly to the public health team, who I know have had a very busy time. Just a question on the regional response, Amanda. Back when the government launched its test and trace thing on the 28th of May, it designated, I think, Middlesbrough and Newcastle Gateshead as local pilot authorities. I just wondered, have we had any information out of those pilot studies that will help us going forward in our outbreak management plan? Because I haven't heard anything since just the announcement that they were going to be the pilots. Thanks.
Thank you, Richard. Yes, certainly colleagues from Newcastle and Middlesbrough, what they have done in their kind of pilot status is they've shared any information that they've had about the development of their local plans, which I think has helped us locally to ensure that the plans have got really, you know, specific elements in terms of the different settings, which may be about vulnerable groups, for example, and how we would approach vulnerable groups in an outbreak situation. I have to say, I don't think any local authority had a lot of time, because all local authorities had to produce the plans within a month. So we've all worked as local authorities with a chief executive from Leeds, Tom Reardon, who was appointed to work nationally on this, which I think has been very helpful because he really understands the local authority position. So I think that was how we were all able to produce and publish our local outbreak control plans by the end of June. I think having Middlesbrough and Newcastle as pilots enabled us to raise some of our kind of concerns and issues, and particularly in relation to access to really good granular level data, and they've done that on our behalf, which I think has been helpful as well.
Do you want to come back, Richard?
No, that's helpful. I mean, it's good. It sounds like they've been ploughing the furrow before us. So, you know, and if we've been able to iron out some of the issues in data and all the rest of it, and getting data consolidated, that's good. I mean, I suppose a supplementary question, just perhaps for Michael as much as Amanda, but all the wealth of data that we've got now, does it point you in any particular directions as to where we are likely to go or need to go in terms of outbreak management?
Michael, I'll come back in on that. We do now have, as Michael identified in the report, we do now have access to all of the positive cases, both those who have been tested through our NHS labs and also through Pillar 2. and that will be extremely helpful. We are now getting postcode level data, which is also very helpful. We just need to know that that postcode level data can match directly back up to the overall numbers of people who are being tested. Our local health protection assurance board has been established because we did have existing arrangements, which I think has stood us in good stead. And we are reliant, and the Health and Wellbeing Board will be that engagement board to help us do that. We are also reliant on local residents and our schools and our businesses also raising any concerns with us if they think people have symptoms, that they are sent home, that they are tested, and raising those potential cases to us and to the health protection team at Public Health England. So I think, as well as having data coming to us from Public Health England and through the test and trace system, it is also about local communities being kind of COVID aware and raising concerns with us, and that's certainly been the case so far. We're also obviously looking at that data on a daily basis and how we compare with other places such as Leicester, such as Bradford. We know that our rates are much lower than both of those places at present, but we are now getting the data through on a more regular basis to enable us to know and to know if we would have concerns. And obviously, as I say, this may be something that the Scrutiny Committee might want to look at in more depth at a future meeting, particularly once our outbreak arrangements are slightly more established.
Thank you, that's very helpful.
Thank you. We now have Councillor Owen Temple, followed by Councillor Tanya Tucker.
Thank you, Chair. Councillor Owen Temple from Concert. Amanda, can I echo the thanks that have been expressed already to yourself, your colleagues, and of course, much wider County Durham. I was particularly going to inquire about a couple of paragraphs, 44 and 82. I think we've all been aware through watching the news on a regular basis of a certain amount of tension between national policy and approaches and more localised approaches from the public health officer's point of view. And so the two paragraphs that I was going to ask about, one was about PPE, because you mentioned that we've developed our own sources, and I wondered how confident and secure they felt if we were to get a re-emergence of kind of emergency conditions. So, and also the spread of who you're supplying it to. There are some figures in the second part of the report that show that, you know, probably just over half is going to local care homes, but there's another nearly half which must be going to an awful lot of other places. And I wondered if you could explain to us, you know, who you are having to look after in that respect, whether it be schools, whether it be voluntary organisations, whether it's our own staff. Give us some idea of the spread of that. And so that was one thing, the PPE supply. And the second question related to what you mentioned about local testing, which you expanded on a little bit. But I think we've got to the point now where we recognise the need for testing in care homes with or without symptoms. I think that's probably fair to say. And so I'm wondering whether we're going to be in a position perhaps to move that into other areas as well. And I'm sorry to tread on Heather's ground, but perhaps, for instance, schools would be a place where our local testing capacity might be directed, because as more and more children return to schools in the future, I think they are a natural place for the transmission of the virus. Not necessarily that those in the schools will suffer, especially because children seem to be quite resilient to it, but because they then go out and they're in an environment where they're together indoors much of the day. So do you think our local testing capacity will have the capacity to move in that direction as well? Because I don't think the national one has particularly gone yet into that direction. Thank you.
Thank you, Owen. If I talk about PPE first of all, and Jane may also want to come in because obviously she's been heavily involved in work around PPE. I think we've taken a very coordinated approach. One of the senior officers at the local authority, Susan Robinson, has led the PPE cell, which is underpinned and liaised with the local resilience forum, which had an additional supply of PPE, and work closely obviously with colleagues in the NHS, and particularly with that supply to care homes over and above their regular supply, to ensure both obviously NHS and our care sector, and now as other parts of the system start to go back, including our schools, that PPE is supplied. And I think certainly what I've heard from colleagues who have coordinated this, it isn't just the supply and ensuring that that supply is in place, which has been extremely fractious at times, but it has also been the quality. And I think the high quality of PPE that has been able to be supplied to our providers across our system through that PPE cell. Jane, I don't know whether you want to add anything in terms of PPE before I talk a little bit more about testing.
Yes, thanks, Amanda. I think just to echo what you've said, and I think picking up on Owen's point around stock going forward and potentially second peaks, it's very much recognising that the demand's obviously still there, and that's something that we're planning for in terms of maintaining those stocks and be able to maintain those supplies where they're required. Certainly care homes is one area, schools has been another area, as well as being able to provide supplies to staff within the council that require that as well, Owen.
And then, Owen, if you want me, if I come back in on the second part of your question, which was around testing and that local need, I think what we've seen from the onset was that obviously detection and contact tracing was stopped, but then there was a national testing strategy published, and that focused initially on pillar one, which was the NHS capacity and testing of staff. And at a local level, and colleagues from the Foundation Trust may want to come in, were very proactive in offering that testing capacity and capability, not only to their own staff, but it was rolled out to the council staff, including any of our essential workers, and also then extended to our care home residents, initially on a symptomatic basis, but then slightly wider parameters. However, I think obviously then what we have seen is the second pillar of that national testing strategy, which is the national testing programme run through Deloitte, which includes the mobile testing facilities. Originally that was placed at IKEA, and then we've had mobile testing units across County Durham, and now there is an established base in Teesside. And I think that alongside that, what we have found with that pillar 2 testing is the results of that were not as quick. The tests were sent to Milton Keynes, so they weren't going through our local labs, and a lot of questions were raised about that testing. And what we've also found throughout the period from kind of March through to recently are a range of national programmes that have been announced. So whereas we were through County Durham Darlington Foundation Trust starting to test our care home residents and offer testing to staff, there was then a national testing programme, a one-off programme announced for residents and staff of care homes in May. And there has just, as of last Friday, been another announcement by government to do whole home testing on a repeat basis, that we're just working through what the actual guidance says in relation to that. So I think there've been a lot of testing happening. We are only starting to get some of those results through from that pillar 2, and it initially was focused on those with symptoms and is now starting to broaden to think about asymptomatic testing as well. I think going forward, in terms of you mentioned whether we should be doing more testing, I think there will be a need and a drive for more testing. In terms of our outbreak management arrangements, we have done some precautionary testing, which is a step in that direction. We will be waiting for national guidance as to whether testing in places such as schools would become more widespread. At present, what we would be doing is, if we have confirmed cases, we would be doing that contact tracing and asking anyone else in their family unit if they had symptoms to be tested. But I think there may be room for further testing, and that is being discussed both regionally and nationally. There is a regional oversight group now for the local outbreak control plan, and a regional testing group, and they are looking at that overall strategy in relation to testing. So I hope that answers your questions. Colleagues from the Foundation Trust may want to come in to say the approach that they've taken very much to try and target our care home residents and staff to get testing in place. But then obviously there was a national testing programme as well, which at times has been challenging.
Sue, welcome. You would like to come in?
Thank you. Just really to emphasise the point that Amanda's made, I think we've been fortunate because very quickly in the event of the pandemic, we've put in facilities that have allowed us to test locally, and that has allowed us to be exceptionally proactive in terms of supporting the wider system, providing those tests into care homes, into other local authority run establishments across the county. And that, I think, with the speed of those tests has helped us to advise individuals very quickly whether they've had COVID or not, and they've then been able to take appropriate action in those circumstances. The drive-through facilities that we've got both in Durham and Darlington are also a very safe and convenient way to be tested. Some of the pillar 2 testing that Amanda described earlier, sometimes the slots meant that individuals had to travel a long way, and we know initially that was, I guess, slightly off-putting to some members of the public. So it's really important that we keep local testing as a quiver in our bow, so to speak, and we are putting in place some more kit to allow us to increase the capacity that we'll be able to do with our own staff from the hospital site.
Thank you, Sue. Councillor Tucker, Tanya.
Thank you, Chair. Thank you, Amanda and the team, for all the hard work, and reiterate everything that has already been said. My question is in connection to paragraph 98 of your report, Amanda. I'll just give you a chance to get it and just give me a nod. It's regarding the 7 themes that have been identified throughout the plan and that will be continued to be addressed. My question is partly regarding data integration and testing. I would think that data integration is going to be key, especially going forward when it comes to contact tracing. Historically, patient health records have been a little disjointed. If someone goes to one trust and then goes to a different trust, the trust don't always speak. If patients change GPs, their health record can be in different parts. Now, I'm aware that there's been a project ongoing for quite some time from a multi-agency approach about having one patient, one record across our health economy. I'm just wondering how effectively and widely that's being used, if at all, and can it be used going forward rather than reinventing the wheel, so that the data we're getting regarding people and testing and other health conditions is robust and accurate? So that's my question. Thank you.
Thank you, Tanya. I'll start, and Michael or another colleague may want to add in to this. COVID is an infectious disease, which is a notifiable disease, and we do have an established way of working in relation to notifiable diseases, that if it was a GP, they would report that into the local health protection team, and there's a surveillance system that would pick that up. In relation to COVID and the establishment of the Joint Biosecurity Centre and the Test and Trace Service, a slightly different system has been established to collect that data. And that is what we have raised to ensure that actually what we know we need locally is that information about all of those cases to flow into GP systems, so that we know who has been infected and affected, and that also that Public Health England Health Protection Team at a North East level can report individual cases or potential clusters of cases directly to us. At the moment, through the Test and Trace service, that information is almost complete, but it does not include things like employer or particular a setting, for example. And we want to see that improve so that we can very, very quickly identify any complex cases and manage that in an outbreak situation. We are and should also then see that information flow to GP records and also to 111 so that we can manage any increase in cases as effectively as possible. So at present, there's two slightly different data systems being used, and what we need is for those to come together so we have one data flow that can help us very quickly identify each one of those themes in that plan. If we are seeing an increase in cases, that we can manage them effectively and slow that spread. But the national system that has been introduced is a new and slightly different system, and we're waiting for it to ensure that we get that data at postcode level locally. Michael, do you want to add to that?
Yes, thanks, Amanda. Just to kind of echo what you've said there. Actually, we've been making a lot of noise locally, regionally, and DCPH nationally about the absolute need to get that granular level data postcoded, so that we can actually effectively trace positive cases and identify potential spread. And luckily, we're building a risk and outbreak map through our GIS capability, which looks at amalgamating a number of risks at a spatial level. So, for example, we've got information there on businesses, we've got information there on our settings, so care homes, prisons, etc. And we're trying to layer on additional information that would help us to plot those postcodes that we have actually received now. We received the first version of that about a week and a half ago now. So we've got an update that came through yesterday in terms of postcodes. We're just making sure that those numbers stack up to what's being reported on the national dashboard. So it's an ongoing process. Things are improving in terms of our access to that granular level data.
Chair, can I come back with a secondary question, please? I'm understanding the COVID element of the testing. What I'm trying to ascertain from the one person, one record type of information is, if we've a person who tests positive with COVID and needs treatment immediately because of its severity, how do we know we're given the right treatment plan, the right care plan, if we don't have the access to their whole health record to determine whether there are any underlying conditions or long-term conditions that might affect that treatment plan? How are we bringing those together is basically what I'm looking for an answer to, because not everybody is 100% healthy, and yes, you may well contract COVID, and God forbid anybody does, because you know the death rate is just too sad to think about. So what I'm trying to get is, how can we ensure that the treatment plan that we're put into place takes into account that whole person and their underlying health needs, as well as their need to be looked after during their COVID process and that treatment process? Do you have something that you could share regarding that, Amanda or Michael? Or is that a question that you're unable to answer at this present time?
I think it's probably one for colleagues in the NHS, because once somebody goes on that treatment pathway, it will be their kind of whole health and treatment that will be looked at. So I don't know whether Sue or whether if Joseph's also in the call, whether you want to describe how people who have been tested as positive and are then on a treatment pathway are actually supported from a whole health and not just from a COVID perspective.
Shall I come in, Amanda?
Yeah, Sue, that would be great.
Just to say, in terms of the record, what our clinicians can get when someone presents at the hospital is basic information on the patient from their primary care records. So the records are to a degree linked together. When you described the project that we're doing across the North East, I think you're probably referring to the Great North Care Record. And what that is that's aiming to link up all the different records that people might have across the different hospitals. But clearly, if a clinician who, for example, sees a patient with us who might ordinarily frequent another hospital for a very specific condition, if that patient wasn't able to provide the information, or if our clinician wanted to understand something in more depth, there's good communication between the clinicians. So I think in the longer term, for things that are wider than COVID, it's the Great North Care Record that you're obviously recalling, and that is continuing to progress. In the short term, I think, as Amanda's described, we've got sufficient so that we're confident that we can pick up aspects of a patient's record that would be pertinent to the treatment. I think the other thing, which is a lot of patients who have been very ill from COVID have a very long recovery, and we think that for some patients that could be many years. And I know we'll go on to discuss things like mental health in the next paper, but we're all also making connections between the different services, so that for those patients that need the most significant amounts of rehabilitation, that is seamless for them.
Thank you very much. That's very helpful.
Thank you. So, Sarah, do you still want to come in? Sarah Burns, do you still want to come in?
Sorry, Chair, I was having trouble with my mute button. Really just to follow on from the points that Sue made, that there is that connection within hospital, but when out of hospital, we have our teams around patients that we have regularly updated the committee on, where we have our social workers, our GPs, our community nursing team, and now with growing involvement from TUV and community mental health services, who work together as an integrated multidisciplinary team, so we can really have that focus on a person's whole needs, not just one aspect of them.
Thank you both to Sue and Sarah. Next one, Councillor Heather Smith. Heather.
Thank you, Chair. Heather Smith, member for Evenwood and Chair of the Children and Young People's Scrutiny Committee. I just wanted to make a comment following Owen's question about whether widespread testing in schools might be needed. I think we should be quite conservative about this, because currently testing for COVID is quite an invasive procedure for a young child to experience. Throat swabs and nose swabs are not easy to do in young children. These things shouldn't be done without a parent present, and to do it unless there's a good clinical indication on a widespread basis, I think would be unjustified currently. We need a less invasive test, but at the moment there aren't any reliable ones. So I think we should think hard about exposing young children to things that might potentially traumatise them. Thanks.
Thank you. My wife, as you know, was in hospital last week, and she said one of the worst things was actually getting the test. She said she did not like it at all. Amanda, I've got no more members to speak, so I'll raise myself. I think the point that you make about the local outbreak control plan is the very point that is the future. It is the way forward. They are going to be more and more important. So yes, the point you make about will this committee be wanting to monitor them, we certainly will, because that is certainly going to be the way forward and go no further than Leicester. The questions I would ask about the local control plan, why are you sending it to the Health and Wellbeing Board to monitor, as opposed to a joint meeting of exec and non-exec members? And if it is going to be monitored by the Health and Wellbeing Board, in paragraph 98 you talk about local boards. Is this where, in the 7 things that Councillor Tucker referred to, local boards, is this where the local members going to be involved? Because certainly in Leicester they've locked down certain wards like Oatby, etc. If we're locking down individual wards, and I'm thinking of places like Newton Aycliffe, etc., what will the involvement of local members be?
Thank you, John. Thank you, Chair. I think in terms of in relation to the Health and Wellbeing Board oversight of the local outbreak control plan, it is really building on the established arrangements that we have in place. So we do have a health protection assurance group, and obviously I reported at the last committee the annual report from that health protection assurance group, and that does report directly into the Health and Wellbeing Board. So when we were asked by government to set up a local health protection assurance board, it seemed to make sense that the existing health protection group kind of morphed into the health protection assurance board to oversee the local outbreak control plan in response to COVID and those key themes that are in paragraph 98, reporting to the Health and Wellbeing Board. And the Health and Wellbeing Board within the local outbreak control plan will operate as that outward means of engagement with the public, so that it seemed to fit very much with the existing arrangements and statutory responsibilities in terms of health protection that it reported into the Health and Wellbeing Board. I think, however, obviously we do have that local health protection assurance group, and within each of those key themes there are smaller teams or groups working. I mean, obviously Sarah and Lee will come on to the huge array of work that has taken place from the very onset in relation to care homes, but we do now have small groups looking at workplace situations, a community group that's looking at both the prevention, and it's really, really important that we stress the prevention elements to all of this, and supporting our local communities as we have done right the way through, and communities taking that real responsibility for taking care of each other. But that in each of those kind of high risk settings that we are developing local arrangements if there is an outbreak. So, for example, if it was Newton Aycliffe, we would be liaising and informing and keeping local members up to date. And the legal powers in relation to a lockdown, and there's obviously been a lot of media coverage on this, the legal powers are as yet unclear. At a local level, we do not have the legal powers to lock down whole of County Durham or Newton Aycliffe, for example. The government on Friday, in the press statement, announced an escalation process. However, we are waiting for further guidance in relation to that. And certainly there's been a report produced from Leicester, which identifies that actually, rather than a local lockdown, it was very much a national lockdown and announced by national government. So I think what we would absolutely aim to do locally is engage with our local members and keep them up to date, and obviously they are that voice of local community, and engaging with our local community involved in the prevention work, and any inkling of an outbreak, we would be engaging with them. I think if it became more widespread, then there would be an escalation process to that, but certainly currently we don't have legal powers to actually close down the whole of County Durham. Even in a school situation, for example, or a workplace situation, we would usually do anything of a closure for a period of time in collaboration with that business owner or a school, rather than in a kind of legal situation. So I hope that clarifies it, Chair, in terms of the legal arrangements and also the governance in relation to the local outbreak control plan.
Thank you, Amanda. And I know how difficult life has been for you, because I was talking to a head teacher who started the morning off one day morning, and by the night time had done 19 different types of report on the same thing, because as the day went on, things changed 19 times. So your life has been extremely difficult. From the committee is finished now on this topic, but we do have Councillor Mr. Mark Wilkes. Mark.
Thank you, Chair. I was actually going to come in on the next report, but it's something that you mentioned there about Newton Aycliffe. In the middle of the main part of the pandemic, I got contacted by somebody who was raising concerns about one of the factories in Newton Aycliffe, Husqvarna. And the response that I got was that I needed to go myself and complain to the health and safety executive about the working practices there. I'm just wondering if the officers can kind of give us an indication, because I understand that if we find out that we've got an outbreak somewhere, that we would move in and start to do whatever's the necessary measures. My concern is that the working practices in many of these factories across the county, we're almost reliant upon whistleblowers letting us know what's going on. And the feedback that I got from the health and safety executive was, well, we contacted the company. They say that they're ensuring there's distancing, and that was it. And it is a bit of a concern there for me as to how much control we do have on the ability of being able to go in, and whether anybody is going in randomly and just checking on some of the larger employer sites where we've got the higher risks.
Thank you, Mark. I promised I only mentioned Newton Aycliffe because it's the largest population to me. I could have mentioned the city. Amanda, I'm not sure if you can answer that one.
I think, thank you, Councillor. I think it's a very fair question in terms of, I think at that point, certainly with Husqvarna as well, we weren't carrying out any active testing, so it was very difficult to actually manage that as an outbreak in the way that we would usually manage an outbreak. We have now engaged actively with the health and safety executive, so both at a local and a regional level, we are very clear about the different organisations that they have responsibility for, and have asked them to proactively provide us with a list of anywhere they may have concerns in relation to compliance. They're also sitting around our local health protection assurance board, and so again, we are asking them to be more proactive if there are any of those concerns, because obviously we have seen in other parts of the country as well as here, you know, in Leicester, in terms of clothing manufacturers, we've seen where there's meat production, and I suppose as well, even what the key thing is, it goes back to the work on prevention. And I know a huge amount of work has taken place through Business Durham and through our local environmental health and community protection officers to work with businesses to get those prevention measures, the social distancing measures in place, the hand hygiene, the shift patterns in place as far as possible, and also their local intelligence on where there may be concerns or there may not be as much confidence in business, and that's also being fed through, and hopefully now with testing and contact tracing back up and running, we would be able to identify very early if we were seeing positive tests from a workplace situation, as long as that starts to get recorded. But certainly we've got health and safety executive around the table now.
Amanda, can I say thank you very much? You've done brilliantly. You've answered everybody's question, and not only briefly but in depth, and I do appreciate, and I know the committee do. The recommendations at the moment are that we note the contents of the report, and we also note that the Director for Public Health will come back with the local outbreak assessment plan. Can we agree those recommendations? Yeah, I'm getting nods. Amanda, I think you, not for very long, I'm sure, but I think it's time for you now to be allowed a slight break. We now move on to item 6.2. Can I welcome Jane Robinson, who's the Corporate Director of Adult Health and Services? And I know you're going to start the report off, Sarah. Jane, I beg your pardon, Jane. And then Sarah Burns and Lee Alexander, two of our guests, will come in, but also our other guests may also want to chip in. So I think we'll move straight to you, Jane.
Thank you, Chair. Good morning, everybody. I'm Jane Robinson, the Corporate Director for Adults and Health at the Council, and this is a really important report for the committee, just giving an overview in terms of the County Durham Care Partnership System response. Chair, if it's OK with you, Lee Alexander, the Head of Adult Social Care, is going to start off, and then Sarah Burns, the Head of Integrated Strategic Commissioning, will follow on from Lee.
Thank you, Jim. Good morning, Lee, over to you.
Morning, Chair. Morning, everybody. Just to outline the general purpose to start off, then, the report provides an overview and seeks acknowledgement for the County Durham Care Partnership System response to COVID and the actions taken. Also highlights the profound impact that the virus has had in County Durham and the strength of the partnership in relation to managing this. It's fair to say that we've had to respond both dynamically and innovatively and revising our approaches, obviously, as the national positions changed in relation to the National Action Plan, guidance, policy, etc. That change has been rapid, it's fair to say, and it feels like perpetual, certainly at times. The pandemic has clearly had a significant impact on the way that health and care services operate in County Durham, and it's likely that this impact is going to remain with us for quite some time, certainly as long as there remains a significant health risk. The strong partnership, I think, that we have in County Durham has been critical in terms of our collective response. What's been common throughout this is, wherever possible, we've obviously shifted the way that we go about doing our business significantly. So we've moved from non-face-to-face working wherever that's been feasible, and obviously used technology across the board. I guess one of the points worth making at this point, and obviously this morning is a good example of that, the use of Microsoft Teams and other sort of platforms have actually made something which would have been almost impossible, I guess, a few years ago, highly possible to sort of manage across the system, and it's been a godsend, I would say. Just in terms of where we're currently at with that by way of overview, so from a health perspective, clearly starting to focus on restarting or gearing up services that have either stopped or have kind of slowed down as a result of the pandemic. And obviously any of those changes or restarts will be very much governed by clinical priorities. From a social care perspective, certainly within County Durham, it's fair to say we didn't really step down. We modified the way that we actually conduct our business, and we're now focusing on restoration and transformation moving forward. And in relation to that, obviously any key interfaces that we've got, any areas of joint interest, we'll be doing that in conjunction with our system partners. There's been a significant amount of support provided throughout this period, and a significant focus in relation to how we work in conjunction with the private sector, predominantly with care homes, and the whole system has really worked collaboratively on that in providing the likes of training, advice, guidance, support, equipment, the likes of PPE, as well as significant financial support. And I'm sure Sarah will actually come on to get into a little bit more detail about that as we move forward. So just in terms of the general background, in response to national legislative and policy changes, there's been a rapid development and implementation of emergency policy and guidance locally by services. And that's been an attempt to try and mitigate against the worst effects of the virus and to ensure there's been service continuity throughout. It's fair to say that we've seen unprecedented change to the way that we've actually had to manage our services throughout this period. It's worthwhile identifying a note of caution here that whilst we appear to have overcome the first peak and have a new kind of business as usual position, it's reasonable to expect that there will be a second peak and possibly could be a third peak thereafter. And obviously we need to continue to be mindful of that. And all of the changes that we've put in place over the last 3 or 4 months, we need to be able to continue to operate in this way as necessary until obviously the worst of the virus has passed us. I think in terms of those changes, many of those have been for the good, it's fair to say. And as we move forward, we will be carefully considering what we wish to retain in terms of these new ways of working. Very briefly, in relation to the response, which is point 14 in the report, the system in Durham has worked together more closely than it ever has done. I would say it's fair to say it's clearly been a joined up approach, collaborative, integrated approach in terms of the response to the pandemic. Nationally, back in March, the NHS declared level 4 incident, which effectively is a national command and control with oversight from NHS England. Similar approach was put in place through local government, and the joining of that together, if you like, there was support through the County Durham and Darlington Local Resilience Forum. Regionally, the Association of Directors of Adult Social Services have played a strong leadership role throughout the pandemic. We've had calls several times a week. Both myself and Jane have been regularly involved in that, and that's been really invaluable in terms of learning from best practice from elsewhere across the region, sharing joint areas of interest and concern, and providing each other with mutual support and mutual aid. Similarly, from an NHS perspective, the integrated care system has provided a similar kind of coordination function. And in addition to that, the local Public Health England team have offered support and coordination at a regional level. And I think key to all of this in terms of how effectively we've been able to work as a partnership has been close collaboration. So locally, just to stress the point, really, I think the maturity of our partnership in County Durham has really enabled us to provide that mutual support to one another and to act quickly where various parts of the system were struggling throughout the last several months. Sue Jakes has been chairing a daily local accident and emergency delivery board. Until recently, at least, that was daily, and that enables senior leaders from across the health and care system to come together to share intelligence, to discuss challenging issues, and to develop collaborative solutions to that as needed. Complementing that, because those calls tended to be early on during the day, we also had an evening system call that took place across 7 days, where again senior officers would discuss any issues that had arisen during the course of the day, and we would seek to find a rapid resolution to those issues as a system, and we would escalate obviously to chief officers where that was necessary. That's proved to be an extremely effective mechanism, and actually as a system, whilst we've been very strong throughout, it's brought us even closer together. In addition to that, there was a mutual aid group that was formulated that Sarah led on, and that focused predominantly on supporting independent sector providers, and I'm sure Sarah will give you a little bit more detail on that as we go through the report. From an adult social care perspective, which is point 37 onwards on the report, I think it's fair to say that the pace in which circumstances changed in March made it almost impossible to plan with any degree of certainty. We were really sort of entering the unknown at that period. And I think certainly the policy and legislative developments that took place thereafter very much reflected that. So in relation to the policy changes in relation to hospital discharge, that required us to work across 7 days, 12 hours a day, and that represented fundamental change to the way that we undertake our business from a local authority perspective. I think what often gets forgotten, it's probably worthwhile just reminding us all at this point, the context, the events that unfolded in Italy a few weeks before that, where we saw the National Health Service effectively unable to cope with COVID, really acted as a sobering reminder in relation for us as a nation and us locally to prepare for the worst case scenario, and that's effectively what we did. In order for us to do that, obviously we had to have a high degree of workforce agility and be able to make decisions and mobilise our resources really quickly, and effectively within about 4 or 5 days we actually changed our operating terms within the service. Again, unprecedented, the sort of changes that ordinarily would take us several months to be able to implement. And we did that with fantastic support, both from senior officers and from staff and from the unions. In terms of complementing that approach, it was important that we had senior management availability throughout. So senior management teams, we were available 7 days a week, 12 hours a day. And that system call was a very important part of how we actually managed to coordinate our responses. Thankfully, the worst case scenario to date hasn't been realised, I would say, nationally or locally. So due to a period of stability, we were able to step down the intensity of the service availability from the beginning of June. So many of our services went back to what were, previously usual ways of working across 5 days, with some exceptions. In order to manage this, obviously working from home became the new norm, and the use of technology such as Microsoft Teams has enabled us to continue our business as usual. Vast majority of our service responses were taking place remotely using video conferencing, etc. We have maintained face-to-face contact when we've needed to, and that's been based upon the risks of individual circumstances. Good example of that would be our adult mental health functions linked to Section and under the Mental Health Act, so our AMPs have had to continue to undertake their business face-to-face, and obviously we've followed all of the necessary guidance, despite the fact that that guidance has shifted quite rapidly, but we've adapted proactively to enable us to do that. A phenomenon, I think, which we felt across the whole system, certainly across the whole of the region too, was when we faced lockdown in the middle of March, a lot of people retreated effectively. Families began to kind of batten down the hatches, look after themselves. And from a social care perspective, we saw an approximate 25% reduction across the board in new activity. And it remained at that level for about 3 or 4 weeks. You coincide that with the expectation that things were going to get worse, It was quite an unpredictable and troubling time. And what happened in reality was activity started to grow gradually after around about a month, and it's now up to near normal levels, I would say, across the board. It's really important, I think, to recognise the commitment and flexibility shown by all concerned. It's been absolutely outstanding throughout the last 4 months. And as we look forward, we're obviously going to have to keep a close eye on the emerging system pressures. And obviously, we will have to adapt our workforce response accordingly should things change again. In addition to us being able to maintain all of our statutory functions linked to the Care Act, including safeguarding, etc., we obviously were having to follow the new national guidelines, and we did that. And I think it's fair to say within Durham we enhanced our response where possible due to our strong partnership work and our size and our resilience. In terms of the hospital discharge focus, the process was very much based around discharge to assess. Policy was introduced nationally, which meant that where patients became medically optimised or medically fit, they were then discharged, moved off wards, and then returned back to their ordinary place of residence quickly within a matter of hours. It's probably worthwhile pointing out at this point, those principles haven't really changed. It's always been the case that once patients are medically optimised, they would return back to ordinary residence or to a place where they would receive further reablement. It's just that the system was required to do that much more quickly than normal. It's worthwhile pointing out paragraph 50 in the report in terms of what that meant for us locally from a social care perspective. So just over 50% of those patients returned back to their own homes and went on to receive either restarts in domiciliary care packages or new services from domiciliary care providers. 40% were admitted into residential and nursing homes, of which 44% of them were in short-term rehabilitation beds. It's worthwhile pointing out, because I think it's often something that gets forgotten, over 50%, so 56% of those individuals were effectively returning to their own home, to their chosen place of residence, which is an important point, I think, to make. The council also developed frameworks of financial and other support to ensure the viability of social care providers moving forward, and I know Sarah's going to pick up on that as we move through the report. So that takes me through my section. Now I'm going to introduce Sarah now, who's going to go on and give an overview in relation to the Commission and the wider system response. Thank you.
Thank you, Lee. So I'm going to start to talk a little bit about commissioning, because as the committee were aware from previous briefings, the new integrated commissioning unit across health and social care actually started on the 1st of March. And some of that development team that we would have done together as a new team has been put on hold. But what we've been able to do is work together to ensure a joined up response wherever we can. So a joint response from health and social care. And the work of the team over the last few months has really been focused on maintaining continuity of service, supporting providers with any issues as they arose, and providing guidance and support. And some of our staff undertook training so they could work in provider organisations such as GP practices if their staff were affected and they couldn't maintain service. The team, as of last month, had made almost 14,000 calls to providers to offer support and seek assurance on service delivery. And we've implemented new systems to make sure we fully understand the position in terms of infection, staffing, PPE, etc. for independent providers. And our providers have had to adapt their services at very short notice in line with national guidance that has changed on an ongoing basis, and I don't think we can underestimate the impact that that has had. I'll talk throughout my update on some of the biggest successes that we've had, and I think from a commissioning perspective it's been our collaborative approach across health and social care, commissioning and provision to work together to discuss issues pragmatically and find solutions, and to be able to move our resource and our expertise flexibly to deal with those requirements as they arose. And I wanted to really just give express my gratitude to the committee, because as the outbreak was beginning in March, we wrote to the committee about the need to make urgent changes to services on the basis of safety to protect people, and we were grateful for the supportive approach that you took to that. Going on to talk about some of the particular areas of care delivery. For primary care, for GP services, we saw those services change very significantly in a very short space of time. So all of the GP practices in Durham moved to a total triage model. So all contacts were triaged and as much care was delivered remotely as possible. And we implemented video consultation very quickly. Our practices were working with the local authority to identify those who are most at risk, so the shielded population, and the practices worked with the community hub to ensure that people had access to the things that they needed so they could stay safe. We've seen greater collaboration and data sharing between our practices, which has really supported that ongoing development of our primary care networks, where our practices work together in hubs, and they were there to support each other if an individual practice had issues. GP practices increased their appointment slots and they increased the ability to order medication online. And I think one of the biggest partnership successes we've seen from primary care is the flexibility of the workforce. We know that some of our GPs have worked in community hospitals, in the out of hours service, and also supporting NIAS in the NHS 111 service. And we've seen real benefits of those changes, and we're looking at how we can retain them. When we talk about acute hospitals, I'm going to focus on CDDFT, but there's a similar position for both Sunderland, North Tees and Hartlepool and Gateshead hospitals where our patients attend, and we do have additional information on those hospitals should the committee wish to receive it. And I think for our acute colleagues, their immediate priority in the outbreak was to free up inpatient and critical care capacity and prepare for patients that would need respiratory support. So those inpatient and emergency department areas have been configured differently, and we have separate COVID and non-COVID patient flows. And our acute estate has had to be used differently, with some services moving from their usual location, and that is based on safety and infection control. Our hospitals, and I don't know if any of you have seen that there's been a great presence on social media around the support that they've given to staff to maximise their availability, to redeploy staff to other areas within the hospital, and regular blogs from Sue and the exec team to keep up the motivation of staff. We've seen changes to hospital discharge arrangements, as Lee mentioned in his update, and some elements of that have worked really well, and we're reflecting on that now to see which bits we want to keep, which bits we want to retain. All referrals to hospital have been subject to clinical triage, with routine referrals and planned follow-ups paused during the outbreak, and full use of the advice and guidance function, so where GPs could write in and get specialist advice from a consultant. But a lot of services were actually maintained in the hospital, so urgent referrals and suspected cancer referrals have continued, and treatment has continued for those patients, reassuringly. The Trust has opened additional beds at Bishop Auckland Hospital, predominantly for frail and elderly people, and that's meant that as soon as their condition is stabilised, they can be moved away from an acute site. And we've seen chemotherapy delivery move from Durham and Darlington to Bishop Auckland and Shotley Bridge, so we can make sure that patients who may be immunocompromised are treated in a safe setting. As the Trust is starting to look at resetting or restarting services, they've developed a set of key principles which have safety and infection control at the heart. So we'll be retaining 2 emergency department entrances and flow throughout the acute medical unit for both respiratory and non-respiratory patients on both the Durham and Darlington site. There will be single multi-specialty non-COVID same-day emergency care on UHND in Darlington in the emergency department, and that's really to make sure that for patients without COVID symptoms, where possible, they are seen, treated and discharged on the same day rather than being admitted for inpatient care. And we'll also have the same functionality for patients with COVID symptoms. Our urgent care services have continued to provide face-to-face appointments, telephone advice and home visits for patients across all of the 4 centres that we have. But really nothing remains on an acute site or moves to an acute site that doesn't require acute site provision. There are challenges in restarting services, and the plans for this are developing on an ongoing basis. So some of the information that's included in the report has already been refreshed and updated. I won't propose to go through the full detail that's included in the report, but just wanted to highlight some of the services that are already up and running. So all cancer services, all priority 2 and priority 3 elective surgery, our urgent suspected cancers and outpatient suspected cancers and urgents, diagnostic services, acute and chronic pain, cardiology services for pacing, angiograms, heart failure, rapid access chest pain, the ability to do iron infusions, support patients that have had a stroke, our ophthalmology services where patients require treatment to prevent sight loss. So for those with macular degeneration, those are already up and running. Our dermatology service for skin lesions, our pharmacy, pathology services, sexual health, contraception, maternity and obstetrics, and our pregnancy assessment unit and support for women who have high risk pregnancies. But also our gynecology services for terminations of pregnancy, colposcopy and postmenopausal treatment. So a huge range of services that are up and running. Outpatient services are being restarted in July, those that had to pause. Our acute frailty services at UHND are starting to get up and running in July, as is cataract surgery and other ophthalmology care. We would expect that all elective surgery will be up and running before October, and the Trust are already doing some of those priority 4 cases now. We'd expect to see routine diagnostics up and running by October, and continuing to work with the private sector who provide additional capacity to our NHS services. But it's worth noting that our hospitals aren't able to operate at the same capacity as before, but the plans in Durham do compare favourably and they're in alignment with those of others across the region and country. And I think as commissioners, we would really flag the absolutely exceptional response that our acute trust has made in light of COVID, with safety of patients really at the absolute forefront. Continuing to work on our proposals for development of a new community hospital in Shotley Bridge. But we need to make sure that the clinical model we propose is considered in light of COVID. We need to look at the services that we can continue to sustainably deliver on that site, which we expect to be inpatient beds and a range of other provision. And we want to go out and do some further engagement work with people in the autumn around that new facility. We continue to be fully committed to the development of that site, and we're going to continue to engage with local members to inform them of the progress that we're making. But we have a period of purdah in the spring, which may mean moving back our consultation timeline slightly, but we will continue to keep the public, stakeholders and members aware of that and up to date with that. And I think an example of partnership success for our acute providers was collaboration with neighbouring trusts to pool resources to ensure that all cancer and urgent work regionally could be prioritised. To community services, as the domiciliary nature of those services has meant that there's been a high use of PPE, and the teams have had to arrange themselves into COVID and non-COVID tasks and arrange their visits throughout the day to protect both staff and patients. So treating those first who are shielding and without COVID symptoms, and then those who aren't shielding but don't have COVID symptoms, then those who are shielding with COVID and those potentially with COVID infection. And it's just structuring those contacts throughout the day to make those services as safe as possible for staff and residents. The services have reduced face-to-face activity where possible and also increased use of digital technology, similar to primary care. There have been 7-day rotas for senior managers and clinical leads, and capacity has increased overnight to be able to cope with any additional pressure that there's been in that period. The community nursing teams and other community services have provided a significant amount of support for care homes, and for services delivered in community settings such as GP practices, we're currently looking at ensuring that we have the space to safely allow those services to restart. There's a big piece of work has been ongoing to understand the rehabilitation needs for people recovering from COVID, and that's work that we're doing jointly with our mental health trust too, so we can address people's physical and mental health needs. We were in a fortunate position of being able to implement testing for symptomatic residents of care homes well ahead of the national programme, and our community service provider were able to roll that out to our care homes within 2 days of us making that request to them, which was a phenomenal task to do. Some examples of good partnership working from community services is where our district nurses supported residential care homes, picking up contact with the loved ones of residents who had COVID-19 and support with the discussions relating to their health condition. And also our district nursing service provided staff for a care home on 2 occasions when there were unplanned staff absences at very short notice. So real collaboration and teamwork there. Moving on to patient transport, been a range of changes there in line with national guidance. We've seen a huge increase in calls to the NHS 111 service. And we've had a number of GPs and other clinicians who've been supporting the NIAS clinical advice service to help deal with the number of calls received. It's been a very challenging time for our colleagues in the ambulance service. There have been additional vehicles on the road during the COVID outbreak, mainly from third-party providers, and the demand for 999 ambulances has been similar to previous years, with albeit a slight increase in April. There hasn't been a statistically significant change in the number of heart attacks or strokes that the ambulance service have dealt with compared to the same time last year, but initial indications would suggest that people have experienced poorer outcomes because they may have delayed calling for help. Really positively, the number of times when a patient is seen and treated by the ambulance crew as opposed to conveyed elsewhere has increased significantly, and that's reportedly due to increased crew confidence and the ability to access clinical advice. But over the next 12 months, NIAS's ability to transport patients will be reduced, because currently they're able to transport one patient at a time. The vehicle has to go off the road and then be fully disinfected, and this is going to be the case for a considerable time. In terms of our scheduled transport, so things like Pts Transport Services, again, vehicles can only transport one patient at a time due to social distancing, although we're currently looking at that and any other options or solutions. And the ambulance service in our hospitals are communicating to understand when clinics are going to be restarted. And we need to identify the impact if more patients are being seen remotely, perhaps by video conferencing, that will have an impact on demand for transport, but also the reduced flexibility in the transport fleet. We need to look at those two things together and make sure that we have adequate provision. And government guidance meant that all non-essential transport during the COVID outbreak was stopped. The number of our volunteer drivers that we had available to convey people to health appointments decreased, as a number of those were shielding or isolated. But we were very grateful that NIAS chose to offer PTS to all cancer-related appointments, not just chemotherapy treatment, across the North East, and that supported a lot of people to get to hospital for their appointments. I think an example of good partnership working around transport was the Durham County Council Transport Booking Team helped NIAS to contact patients when we had to cancel those non-essential bookings, and it was great to see the services working together. In terms of care home support, you can see at Appendix 5 of the report, we were required, as all local authorities and CCGs were, to develop a care home support plan, and that lists some of the additional help that we've provided to care homes. Early in the outbreak process, we implemented a tracking tool so that we could understand and prioritise support to care homes most in need. We have, I think, 152 care homes across County Durham, both older people's and specialist learning disabilities, mental health, supported living. So a very high number of providers to support. We worked with colleagues from public health, community nursing services, CHUV community mental health teams and their care home liaison team, the infection prevention control team, safeguarding and the CQC. And we've met 3 times per week. The CQC join us weekly to discuss care homes, to understand what our data from our tracking tool is telling us around staffing, absences, number of infections in a care home, number of deaths, how much PPE they have, but also to share that soft intelligence, so people that have actually been in and visited the home and seen residents there and have shared information with us to help us understand any additional training, advice and support they may need. So we've had a big focus on older people's care homes, but we've had a mirrored approach for specialist care homes that's been heavily supported by our colleagues in CHUV. We also developed an additional assurance approach where if we had concerns, we go in and visit that care home and go through with them in detail their approach to delivering care across a comprehensive range of areas, and work supportively with them to put in place any improvements they may need or to provide any additional training, advice and support. And that's been delivered by Lee's team for older people, and CHUV have supported with both learning disability and mental health specialist care homes. We've developed a financial support and mutual aid package for all care homes across Durham, including a cash advance to support their, that's a recoverable cash advance to support their cash flow. We increased their annual uplift from 4.5% to 5%, which has been paid from April. We've implemented the system-wide mutual aid approach, so where That's included redeployment of staff to cover providers who are experiencing significant pressures. And we've done a recruitment campaign through the County Durham Care Academy, and we've had 200 applicants since that recruitment campaign began, and that allows us to fast track candidates to work in care. Our older people's providers have been paid an additional 10% uplift on top of their fees, and that's for both local authority and NHS funded and self-funded residents. And we are keeping that in place until September, and that will be reviewed on an ongoing basis. And we've also supported our ability to maintain market capacity through block purchasing a number of vacant beds to enable step up for people in the community requiring 24-hour care, or step down for people being discharged from hospital. But that's in line with where providers are able to do that safely. And we've also distributed the government's infection control fund to adult social care providers. So that provides additional funding for them to make infection control measures. We are very lucky in Durham to have a dedicated infection prevention control team, and they are specialist nurses who support the whole health and care system, but they've provided additional support into care homes and hospices since the pandemic was declared. They've provided practical advice, support, virtual training and demonstration of approaches, and have been on hand to contact any care homes that we feel need additional input. And prior to COVID, they had actually developed infection prevention control champions within every care home. I think in terms of partnership working, I think the way that we were able to develop our mutual aid approach quickly and collaboratively, and that's a case of understanding the problem and working together to find a solution. And I think another one where our local palliative care consultant, David Oxenham, provided virtual training and support on end of life for all of our care homes. Moving on to mental health and learning disability services, the teams have implemented remote working wherever possible to support people with emotional and mental health needs during lockdown, and there are examples of some of the adaptations included in the report. Teams have seen referrals gradually increasing, and admissions to inpatient beds have increased. There's been specific targeted work for people with a learning disability, and the Keeping People Connected programme has ensured that adults with autism or a learning disability are supported by proactive contact by phone and ensuring their needs are met, and our voluntary and community sector is closely linked into that work. Our mental health and learning disabilities teams have provided significant input into care homes, and they continue to support that in that local multi-agency mutual aid approach. And as work now starts to enter the recovery stage, plans are being developed by the services to be able to continue to support emotional well-being and mental health and prepare for the challenges that will come post-COVID. And while those mental health needs are going to be greater understood over the coming weeks and months, we think that the factors that affect mental health, such as financial worries and isolation, will create an increased demand on services for both adults and children. In terms of partnership working, we're very grateful that TUVE have led on those assurance visits to specialist mental health care homes, and have also provided psychological support to both health and independent provider care staff wherever that has been required. As we think about recovery planning, hopefully it's clear, as I've talked about each sector affected, that COVID is going to be around for an indefinite period, and we need to retain our response arrangements. They have to be strong, they have to be proactive, while also considering how we broaden our work programmes and we look to a new normal. We need to learn from the experiences we've had, and we've moved a lot faster by working together, and we've worked flexibly, and we've tested new ways of working, often at very short timescales. So recovery isn't going to be an immediate return to our pre-COVID infrastructure or operational delivery. It needs to consider the population need alongside health and care urgency. And the benefits of our integrated delivery and integrated commission are really there to support our swift return to full service delivery whenever that is possible, but to also respond to any future COVID waves or perhaps a flu pandemic during the winter. And we're working in partnership to ensure that recovery work is aligned wherever that's possible, and wherever it's appropriate across both commissioning and delivery. And really just to finalise around engagement, so we're working together across the partnership in Durham, so that's the local authority, the CCGs, TUV, CDDFT, and with Healthwatch to understand people's perceptions of health and social care in Durham to help inform our future priorities. And we have to be mindful that people's perceptions may permanently change as a result of COVID. And as part of that, we're keen that we engage as much with staff, and that's recognised as very important, as well as the public. We're working to understand the impact of those new ways of working that they've had on people, and we're engaging with them over the coming weeks and months across primary, secondary care, mental health and social care. And we're working with Healthwatch on a proposal around that, which we'd be happy to share with the committee for comment or input. And we really need to make sure that everybody's needs can be met and that nobody is excluded as a result of moving to new ways of working. And we may find that some of those new ways of working are better than those we had in the past, and we may want to recommend that we permanently change those, but we will continue to work with the committee on that in the way that we always have. So that concludes the points I was going to make. I don't know if any of my colleagues from the partner organisations would like to expand on their particular area.
No, I don't think. Sarah, somebody. Is that better? No. Sarah, when you listen to that report and when you listen to Lee's, I've wrote down tremendous, unbelievable, exceptional, extraordinary, selfless, and I think all say that every single partnership that you've worked with across health and social care, it's been the greater good of the community at the front, and I think that has to be said. And I'm so glad that we're being recorded for once. Normally we'd be in County Hall and it would be forgotten. And I do hope somewhere along the line that them words are kept, because every single one of them is reflected on the report you've given. Thank you so much to you and everybody else, Sarah. I've got a number of people wishing to ask questions. So can I start with, and I think the one we all thought would come in first, and being a betting man, I might lose a lot of money here, but I think it may be Shotley Bridge we're going to get a question on. It's Councillor Owen Temple.
Chair, thank you. I actually had questions on the main report, which I'd like to come back to if I may, but obviously Shotley Bridge came up, as it were, as part of Sarah's talk. So can I say first of all that I welcome the reassurance that there is no diminution of intention, but I am a bit concerned because we've passed the first milestone, which was in the last report, and that milestone was that the business case would be completed by the end of June. The next milestone was that consultation would start in September. We know that clearly COVID has affected everything, but I think local people really could do with some assurance about when consultation is going to start, because you mentioned engagement. We've already been through a period of engagement. So can you give us something firmer on when consultation will start? And you're quite right, local members get information, but we get it under conditions of confidentiality. So we actually need this committee, which has been fantastically engaged with this all the way through, as with all our community hospitals. I think this committee needs to know, and the wider public need to know what the thinking is on that. So if Chair, I could ask that and then come back on the.
I wouldn't dare do anything else, would I? Can we have the answer to that one, please, Sarah?
Yes, Chair. We are going to be sending some comms out to the public following the meeting today, but I'll bring Rachel in if that's okay, just to provide some of the detail.
Thanks, Sarah. Can everybody hear okay? Yeah, so just to give some reassurance, as Sarah said, there are a few challenges in terms of our timelines, one of which that she mentioned was around PERDA. Our intention is that because we need to review the clinical model in line with the impact that COVID has had, that we would like to engage in autumn this year. As you know, Councillor Temple, we did some engagement last year. However, things have significantly changed and we need to bring the public with us on that journey. And the fact that we do need to have further discussion on that clinical model before we can then move forward with our discussions around building solutions for the new facility. So the idea is we would engage in autumn this year, and then we would go into consultation on the site of the new facility June next year. When you look at the overall timeline, it sets us back around about 6 months from the original sort of proposed spade in the ground, which in terms of a building solution, you can expect some delay. We hope to do as much as we can behind the scenes and doing that alongside the work where we're engaging with the public so that we don't lose too much time in the overall programme. But as Sarah said, we have got a comms piece that's going out hopefully today. The reference group should have sight of that was sent this morning for them to view, giving a little bit more detail to the public to make sure that they are aware of our commitment as a local system to continue with the Shotley Bridge project.
Thank you, Rachel. Back to you, Owen.
Thank you, Chair, and I'm very pleased that comms are going out today. That's really important to me. Thank you. On the report generally, whilst, John, I agree with everything you've said about the fantastic amount of work and effort that's been gone through by so many of our staff, of NHS staff, of partners staff, I do think we need to be also quite deeply questioning of some things. I think there's a challenge in our society which a lot of people feel, which is that we're not very good at holding our hands up when we don't do things as well as we would wish we had done. And I do think that in this committee we need to bear that in mind, because the public at large, and we know we're on very, very sensitive ground here, but the public at large want to know what we think we might have done better, as well as all the things that we have done. So that's a very general question which I would put to both Sarah and to Lee. But there's a very specific area I did want to ask about, and that is on, sorry, while I get to it on the iPad, it's in paragraph 51. And this is about discharge from hospital, which has already been touched on in the earlier report. And Michael has been fantastically strong on the statistics this morning, so it may be that he might come back on this. But the figures that are in that paragraph tell us that 40% of 1,205 people went to care homes, but other statistics that I've been sent this morning from within the council say that there were 287 discharges of individuals after inpatient stays. So I begin not to understand the statistics when I can calculate that 40% of 1,205 is 480, but 287 discharges, and that was in response to a specific query about how many of the people who were discharged had not been tested prior to discharge. So the figures that I got for that were that 16 were believed not to have been tested before discharge. But if the number is actually 480, not the 280 something in the email that I got, which was from the council, then what do we really know about the proportion of people discharged who were discharged into our homes without us knowing whether or not they had a COVID infection? Because Michael said to us that we have statistically challenging position in relation to our deaths in care homes. And again, I wanted to be clear in the case that he was talking about actual deaths which occurred within the care home setting, because I know the Office for National Statistics works on a different basis. It talks about deaths of care home residents, but then differentiates those who died within a hospital setting and those who died with a... So the very specific question is, what do we know about, in terms of numbers, what do we really know about the number of people who were discharged into care homes from hospital untested? What do we have on a numerical basis for that? And I'm sorry, because this is such a difficult area, and some of the people who are watching today will have been directly affected and will still be grieving relatives. So I'm only looking to try and find out the reality. None of what we do today should be about, you know, kind of any kind of criticism. It's just about trying to find out and scrutinise the facts. So can somebody shed some light on that very specific, and then perhaps talk about things we might have done better? I think I can see Sue Jakes' hand is up, so I'm going to shut up and listen.
You're quite correct, Owen. That is our role, to scrutinise, and that's what we're here for. And everything you've said this morning, you're entitled to say. Actually, there was one person ahead of Sue Jakes. You've got two ladies asking to respond to you. So first of all, we've got Jane Robinson, our director, and then as soon as Jane's finished, straight to Sue. Thank you, Jane.
Thank you, Chair, and thank you for the question, Owen. And I think you're absolutely right. It's a very sensitive area. It's also a very complex area in terms of the data. I think the difference in terms of data sources and also the timing of data. I think to answer your very specific question in terms of the information that you're referring to, because I know what that information is, and we can come back and clarify the detail, but the information you have is specifically around CDDFT in terms of those discharges. Whereas I'm assuming the information in this report, but I will clarify for you, refers to all hospital discharges. And as Sarah referred to earlier, we're not just working with County Durham and Darlington Foundation Trust, we work with a number of other hospitals. So the breakdown, and I think that's part of the complexity, is the data from a number of different sources. I see Michael's nodding, so I've got that right in terms of that particular piece. But I think that's why there'll be a difference in those figures, Owen, because your information you have is specifically, the question was asked around County Durham and Darlington. This will be the totality, but we can work through some of the detail of that outside of the meeting. I'll probably hand over to Sue if that's okay, in terms of your specific question around the testing, if that's okay.
Thanks, Jane. I was just going to be clear that it is just our trust's figures, the 287, and of those 16 that weren't tested, we are checking some of those records because 3 of those are after the 18th of April, and the significance of the 18th of April is there was some change in the national guidance. So at the minute, the records that we've got show that there are those 3, but I am having them looked into, Owen, because particularly 2 of them look as if it's possible that they may have been tested and that it's not been put onto the system, but I need to double check. So I've given you the worst case at this stage.
Thank you, Sue. We've got you're doing well here, Owen. You've got Lee Alexander wanting to talk to you, and you've got Jen Robinson wanting to come back. Lee?
Okay, thanks. Just to clarify and reiterate, really, the points within this report does actually refer to all data. So any County Durham resident on our client database from any hospital in the region, and also just to pick it up on Sue's point, it obviously predates that April date when the guidance actually changed around testing. So that helps to explain the apparent discrepancy, if you like.
Thanks, Lee. Jen, I notice you want to come back.
Yeah, thank you, Chair. It was just to pick up on the challenge, quite rightly, that Councillor Temple was saying in terms of things we would have done differently. And I think there's obviously been a lot of really positive messages in terms of the response and actions that have been taken across the whole of the system and within our communities. I wouldn't want members to think we're complacent. We regularly review and challenge ourselves in terms of the actions that we've taken. And one example being, you've obviously seen in the attachment the care home assurance plan, and that's been looked at across regional colleagues in terms of that kind of sign off of that plan, if you like. And we also challenged ourselves within the corporate management team, including Sarah and Amanda in that is there anything else that we could or should be doing in terms of supporting our care homes, and we'd also want to consider about how we bring external people in to kind of potentially support that review. So I think the absolutely reviewing what we do and taking stock is something that's part of the ongoing work that we do, Councillor Temple.
And time is on our side in one way, Jane, in that over the next few months we will have time to reflect and look back, both yourselves and us as a scrutiny committee, on various parts of things that have happened and work you've done, and obviously the national look at, the national inquiry into it, we will be able to compare with that as well. Owen, you're doing well here. You've got Michael wanting to come in, you've got Sarah Burns wanting to come in, so you're doing well for one question. Michael and then Sarah.
Thank you, Chair. It was just really to echo what Jane and Sue mentioned earlier in terms of the data. It's quite a difficult thing to link the two disparate data sets together from my understanding of asking that question to colleagues at CDDFT. So it isn't a straightforward task to link that testing data to the patient administration system, the discharge system. So it was just to make that point.
Thank you, Michael. And your last responder now, Owen, is Sarah.
I'm probably not answering the question as you would have liked, Owen, but I think that there's a couple of things that we perhaps hadn't mentioned, and I think when I talk to colleagues in other areas, sometimes the challenge is around whose responsibility is it to do something. Is it health, is it social care, is it a commissioning, is it a provider responsibility? And I think in Durham we are so far past that hasn't been an issue at all, so that we've been able to work has been so much easier, problems have been so much easier to address in County Durham than other areas. I think issues that other areas struggled with are digital technology. And I think we were stood in really good stead in Durham that we have a dedicated supporting the provider market team. And we have staff who work together across CDDFT, TUV, the Council and the CCG on digital technologies. So we had 92 of our older people's care homes pre-COVID already had a digital healthcare solution in place, which was huge. And we were able to get all of our care homes using secure NHS mail, which helped remote working significantly during COVID. So that was an area that was an issue other areas perhaps struggled with, but we were on the front foot with. And I think the other one, I couldn't leave here without really highlighting the work of our infection prevention control team. So we have our own dedicated team in County Durham of specialist infection prevention control nurses. And months before national guidance was issued, our team had offered support to all care homes They carried out virtual training. They contact homes on a regular basis to talk through their concerns. They've worked tirelessly, really, to support that agenda, and we've had support from our Acute and Mental Health Trust to deal with additional challenges around providing infection prevention control support to schools too. So they are areas that have been issues in other authorities, but actually in Durham, because we're lucky to have those teams, it's really stood us on the front foot, and I just wanted to highlight them because I perhaps didn't do that sufficiently when I presented the report.
Thank you, Sarah. So we now move on. Thank you, Owen.
Can I just come back, Chair, to say thank you, and thank you for the promise, really, that we will get to the bottom of those figures, because there's a very big discrepancy. It's 190 something difference between the 480 and the 287. Yeah, so that's a very big difference. And if they were coming from a wide range of other hospitals, we need to know where they were coming from, and we need to know whether the testing position was any different from the other hospitals from CDDT, Sue, or whether actually the pattern is a wide pattern and is a national pattern. And can I hold up my hand for one in saying about things that I think I, as a member of this committee, have done wrong? I don't think in this committee I have ever asked for us to talk directly with the leadership or the staff of care homes, because we deal with partners all the time on this committee, and I have never thought to ask that we meet with and hear from them, and they're a huge part of what we do and what our work is. So I just want to hold my hand up on that one.
Thank you. You're quite right, Owen. We have North Tees and Hartlepool hospitals, we have Sunderland, we have Gateshead, South Tees, so we do have a lot of, we're not like some authorities like Newcastle who just have Newcastle hospitals. We've got numerous ones. And I do know Jane and I have had conversations about our adult social care and involving them more. So I do know Jane is talking about bringing adult social care and care homes to future committees. So I do know that that has been looked at. Thanks, Owen, for this morning. Your contribution and the responses have been excellent. Tanya, can we come to you, please? Can you tell Councillor Tucker?
Thank you, Chair, and thank you, Sarah and colleagues, for a very comprehensive and positive report. I really enjoyed reading it, and it didn't put me to sleep. So thank you very much for that. I'd like to ask two questions, if possible. Firstly, paragraph 59 on page 57 of the report, regarding the County Durham Care Academy and the recruitment, the recruitment of extra bank staff who've been given training, had their DBS checks, and the number of applications, I must admit, is really encouraging. My question is, COVID is probably not going to leave us until we find a cure, that we're always going to have it in some way, shape or form well into the future, I would think. It might be to a very much lesser degree, which God willing will occur. At some point, our hospitals, our GPs, our care homes, our care providers, in domiciliary, etc., in any setting, we've always struggled with staff numbers, and we are going to struggle going forward. And it's not a job anybody can do. It takes a very, very special type of person to work in care. It's not the sort of job you can come, do, go away and forget about. That's not the type of person who enters this profession. My question is, what career progression or what training progression going forward have we put in place, or will we be putting in place, to ensure that we do have succession planning, we do have the numbers of staff we will need going forward? I mean, as our age range of people working in the NHS gets higher towards the sort of retirement age, which we all know is happening, what are we doing to encourage the younger generations to look at careers in care at all levels, because we will need those numbers. Otherwise, if we have a full-blown pandemic in the future, we may not have the numbers of people to be able to look after us. So that's my first question. And if I may, Chair, could I ask for the answer to that and then come back to my second question, because I think there might be a number of people who would like to chip in, if that's okay with the committee.
Well, at this moment in time, Tanya, you've got Sarah Burns. Sarah.
That's lovely. Thank you, Sarah.
Thanks, Chair. We had workforce issues in care provision pre-COVID, and what we're trying to understand now is how that has been impacted. So we are working closely with all of our care providers to understand what that impact has been and is going to be on a longer term basis. We're collecting information with them to understand some of those pressures, and we are looking at what solutions we could put in place. There are a range of different models for care provision and delivery. We work in an integrated care partnership in Durham, so we'll be working with our colleagues in the NHS to see what some of those solutions might be. And that is a work in progress, and it's happening alongside the immediate work we're undertaking with care homes around understanding their sustainability. So I guess two priorities there. One is making sure that care homes are sustainable during COVID, and the other is looking at the medium to long term model for care delivery in Durham. And we would be quite happy to bring a report back to the committee on the work that we're doing around that. Some of it is talking to providers, and some of it is talking to staff themselves and the public to understand their perceptions, because what we can't assume is that people's perceptions of care will be the same post-COVID. So it's understanding how they have changed, what people's preferences are for care in older age and for specialist care as well, and how we can develop an offer locally that meets that.
Thank you, Sarah. That detailed report would be helpful to understand the shortages that we faced in health and social care for a number of years. My next question is a slight follow on, if I may. It's to paragraph 64 regarding appointments in general practice, and we all know there is a shortage of GPs. That's been ongoing for more years than I care to count, as you will probably, and other colleagues will probably be aware. So my question is, GPs have really stepped up to the plate. The GP practices really have stepped up to the plate with the way that they've taken on board the fact that we were in lockdown, people were shielding, self-isolating, other methods of trying to keep safe in line with government guidance. And all credit to everybody for translating government guidance, because every time I read it, I always thought it should have just been in Swahili, because it didn't make much sense, and you've done a phenomenal job, so all credit to you. My question is, given that patients have still been able to access GP services, although in a different way, whether it be a video conference, a telephone appointment, whatever, it would be helpful to be able to understand if more people have been able to ascertain appointments through the new system, through the new way of working, than would normally have been able to get a face-to-face actual appointment with GPs, and whether that GPs themselves, as well as patients, have felt that has been more appropriate to have that telephone or video conferencing appointment, and would prefer to do it going forward rather than getting ready, sitting in the GP practice, waiting for the doctor, etc. That could go about normal business and just wait for a call. So I'm just wondering how much of the new ways of working have been effective, given the numbers of given the limited numbers of GPs in practice in the UK at present and the difficulties recruiting. How much of this current way of working is likely to stay with us and would prove effective and more beneficial on GP time and practice time? So I hope you understand that question, and it was a little bit long-winded. I do apologise, but that's what I would like to discuss. Thank you.
You're getting positive nods from two people, Tanya. First one is Rachel Rooney, and then the second one, Sarah Burns. Rachel?
Yeah, I just wanted to pick up on the point that you made, Councillor Tupper, about staff and patient perception and new ways of working within primary care. We've actually kicked off a piece of work with GPs.
Sarah, can I interrupt you, Rachel? Are members struggling to hear Rachel, or is it coming over all right?
She's a bit patchy, I'm afraid. I'm sorry, Rachel. You're a bit.
Apologies.
That's perfect.
I can you hear now?
Yeah.
I'm shouting a bit louder. So we have undertaken a piece of work looking at a survey for staff within primary care, both GPs and other primary care staff, to understand their views on the new ways of working. And in tandem with that, we've done, in connection with the Integrated Care Partnership across Sunderland and South Tyneside, we've kicked off a piece of work looking at patient perceptions of the new ways of working as well. To date, we've had over 900 responses to that survey, and we're currently doing the analysis on that to see how patients have felt about total triage, Skype consultations, etc. So I'm more than happy to share that information with the committee once we get that through. But that's something that we want to build on further to understand from a staff and public point of view how the new ways of working are panning out and whether or not it's having an impact on efficiency and effectiveness as well.
Thank you, Rachel. I think we really would appreciate that. I think that's one of the things we will all be looking at, new ways of working, not just for health, but across the whole of the scrutiny committees. Thank you, Rachel. Sarah?
Thank you, Chair. I think it's just to follow on from what Rachel was saying. It links to a point I made earlier that different ways of working will suit some people, but not everybody. And it's making sure that services are delivered and they're comprehensive to meet everybody's needs. I personally would love the convenience of a virtual appointment, but I know people equally who would rather see the doctor. And I know some doctors who manage very well with it, but there are some conditions where doctors need to lay their hands on a patient and examine them. And it's being able to make sure that the model that's in place covers all of those options. I think what we also have to look at is the example I gave of GPs working in our community hospitals. So in Chesley Street, I think Sue would agree that the GPs working there made a real difference. And actually that's something as a system we think is probably important to retain. So it's looking at where all of our different clinicians add value into the system. And it's some of those are trade-offs that puts additional pressure on our GPs, but that makes a big improvement in hospitals and flow within that hospital. So it's looking at the trade-offs in all of these things and looking at where our clinical resources is best placed for the whole system. In terms of number of contacts with practices, we do collect that. And we do look at that, how many face-to-face appointments, how many with GPs and nurses, and we can look at the trends for that. What we do know is in the early stages of COVID, we saw a huge increase in calls to NHS 111, and in some cases GP practices were very quiet. So that pressure has moved around the system, and I think I hopefully described in my update how the staff moved around the system as well. So where GPs were quieter in practice, they supported the NHS 111 service and put their resource into there. And I'd like to hope that that experience has shown our clinicians, it's demonstrated to them how they can work together differently. and builds a platform to move forward from, where we do look at people perhaps moving behind what would be their ordinary boundaries, but makes the most difference for people and for patients.
Thank you, Sarah. We now move on, and thank you, Tanya. Thank you very much. We now move on to Councillor Bell. Richard.
Thanks, Chair. Yes, I'd just like to talk a little bit about NHS estates and physical capacity and space, etc. Because you mentioned, Sarah, in passing that you'd used more beds at Bishop Auckland Hospital as transition between acute hospitals and home, and that's great. And it's great that we actually had those beds in Bishop Auckland Hospital to use. And I know you sort of surveyed also Richardson Hospital in Barnard Castle, where we have spare beds, and the spare capacity in the community hospital at Sedgefield as well, and I dare say elsewhere across the county. And one of the issues in the past that has actually driven you away from using the community hospitals and to condense services into the acute hospitals is the fact that NHS estates have been charging silly rents, because these are PFI facilities and NHS estates like to get a return on their money. And that's actually driven us into condensing services in physical locations. So there is capacity there for you to be able to expand physically where necessary to take account of COVID. So I guess my question is the NHS as a whole, and NHS estates in particular, are they going to be sensible about using the capacity that we have got, the physical capacity that's sitting there in some pretty new facilities that's actually quite grossly underused at the moment, to be able to reconfigure our services going forwards? That's my question. I mean, I drive past on my way to Barnard Castle, an old isolation hospital, in the days when we used to take people out with scarlet fever, etc., and put them in isolation. Over the years, we've entirely abandoned that way of thinking. We're kind of like reversing that a little bit now, or having to reverse it a little bit now. And I just wonder where you see that going from an estate's perspective in the future. Thanks.
Thank you, Richard. I was about to say I don't know who's going to answer this, but Sarah's going to answer.
I will, but I'm sure Sue will come in on this question as well. I think in terms of our estate, we pay for the estate whether we use it or not. So we have costs in the system, so it's in our interest to make the best use of that estate. We know that to deliver services safely through COVID, we can have fewer people in waiting rooms, we can see fewer people in clinics. So we need bigger space, larger footprint to deliver services from. I know Sue particularly will pick up on the issue around Bishop Auckland, but we know COVID's going to be around for some time yet. So we've had to have a service configuration to deal with the outbreak. There'll be the medium term way that we need to deliver services. And I think I mentioned in my updates or my introduction to the report that some of those changes may be really beneficial, and there might be things that we want to keep for the longer term. And we need to look at that. And I know that we're already starting to ask people their experiences as they're using services to support if a more permanent change is needed. But in terms of condensing services, yes, estate costs are an issue, but another one, and I'm sure Sue will pick up, another compounding factor we have is availability of staffing and clinicians for those services. So we have to take that into account when we're considering how we want to propose to deliver things in future.
Lovely introduction to yourself, Sue.
Thank you. I think I'd begin by saying, because we've got a number of different community hospitals, it's been advantageous to us. And when we compare the way in which we've been able to respond to COVID, it's been helpful to have that additional estate. As Sarah has described, that estate gets paid for by the NHS regardless. And one of the things that we normally have as a competing factor is the availability of staff, particularly if you're running an unselected take off a site, i.e. running essentially an acute hospital, because you've got to have senior medical cover there at all times. What we've been able to do during COVID is provide that into Bishop Auckland, not into the other community hospitals, but into Bishop Auckland. And we've done that because we've stood a lot of other work down or paused other work. So we have had, for example, orthopaedic surgeons running A&Es on the Durham and Darlington site. and everybody's being redeployed within their competency into a different area, which has allowed us, in combination with a lot of our recently retired consultants who agreed to come back into service, to run Bishop essentially acute over the COVID period. And we did that because the initial modelling suggested we needed to be able to create 400 extra beds. And we were able to do that because we could redeploy the staff and we had the physical space. That was not a luxury in some of our colleague organisations in the North East. As it turned out, we had about 160 COVID patients at the peak that we incurred. So it was a lot less than we'd anticipated. But what we have seen, which Sarah's referred to, is because in the community hospitals, so the Richardson, Shotley Bridge to an extent, Chestler Street, and the others, because we put in a little bit of a different model and had a more GP concentrated medical input into those services, as the clinical staff that ordinarily work there were helping with the arrangements at Bishop, what we saw is that GP input giving us shorter lengths of stay. Now we need to unpack exactly how all of that's worked, but I think that's the aspect of things that Sarah has said would be useful. And earlier on, Amanda was talking about winter, and we don't know whether we'll get a second spike. I think most people think there will be one, but what we're doing now is planning for a winter when we might have a second spike of COVID and the ordinary flu, and need to be able to scale up significantly our facilities. And I think those new ways of working, including that GP involvement in the community, the redeployment of staff, will stand us in good stead. So some of the wards that you saw, we physically got all of the beds, for example, available to open up the second ward on the Richardson, as it turned out, and thankfully the amount of COVID meant that they weren't necessary, but at least it means we've got the physical space should that ever be required in future.
Thanks, Chair, it's very useful.
Thank you, Richard. Thank you, Sue. Okay, we now move on to Alison Beattie.
Good morning, Councillor Alison Beattie, one of the councillors in Pelton Division, Vice Chair of Scrutiny. First of all, just like to thank you all for all of the hard work and effort that you've actually put in locally. I've got every faith in our local medical professionals, obviously in your field. However, some of the queries that obviously have been experienced locally, in North Durham, around sort of cross-border issues, around sort of numbers of admissions to other health authority areas. It touches on what Owen's already said. Some of those statistics are a little bit ambiguous for certainly local residents, and I think we do need a little bit more clarity on that, so I welcome Owen's point. Also, it's touching on, and I didn't know whether to mention this in part A of these issues with Amanda, it is around the messages that's come out loud and clear. I'm looking at my pieces of paper here. The message seems very, very clear, and I know sort of even this piece of paper that I got around sort of the requirements PPE wise in various settings around dealing with COVID or non-COVID patients. The reality was, in early days we did not know who was a COVID patient and who wasn't because of the lack of testing. That's played out, I think, unfortunately in some of the sad figures that we're now actually reading. What Amanda's actually emphasised lots throughout her presentation was local testing, local responses, sort of adhering to national guidance, welcoming the local outbreak control plan. I've got to confess, due to need in the community, I haven't had the chance to read that in detail yet. I'm looking for sort of some of those things locally to look to have them implemented, should, heaven forbid, we end up with sort of a second wave. But more importantly, looking at those lessons learned now, not waiting for sort of any sort of national inquiry or anything. I welcome that actually happening now, and as locally elected members we all have a role to play in that, from what we've actually experienced locally, the knowledge that we've actually got, and it would be really good to touch base once sort of things have quietened down a little bit with what we know has been going on in our communities. Also, the infection control teams, I'd just like a little bit of clarity on that. We're all aware there's premises within our communities that's now starting to reopen, for example, some community centre buildings. Can I just ask, is that infection control team going to be working with facilities like that? If somebody could just answer that question for me. But welcome, obviously, all of the communication that has come so far. But I do think there's some local things, as Amanda's emphasised several times, that we can still be doing. Thank you.
No, thank you, Alison. Excellent. Can anybody talk about infection control? No, I think that maybe Amanda is. Thank you, Amanda.
Thank you, Alison, and we'll certainly, I think, build on the role of local elected members in this next phase, absolutely, in relation to that being their eyes and ears, and obviously right within local communities, just as members were particularly supporting the community hub and people to have food and support. So, you know, we'll absolutely take that on board with the local outbreak control plan. Obviously, Councillor Hovels is in committee as well. In terms of the infection prevention and control team, they don't directly offer that support into community facilities. Obviously, Sarah may want to add to that. However, I know that within the council that we have been obviously working with facilities to provide some advice and guidance and kind of risk assessments that community facilities can use themselves. So I'm more than happy to pick up that, you know, make sure you're connected to the right person outside of the committee to get that advice and information, and also through the kind of community group for the kind of local outbreak management. I'm going to work with Jill O'Neill and Gordon Elliott to really think about those community facilities and ensuring we can do that preventative part and be ready in terms of any outbreak. So I'll get that connection in terms of the kind of risk assessment for community facilities. But unfortunately, the infection prevention control team, I mean, they have, like Sarah said, they've absolutely come into their own, but they they've been really pointed particularly around originally kind of healthcare acquired infections, do a huge amount of work both in social care, within the community healthcare setting, and actually we're hoping to build on that team specifically around some of our special education needs schools, as particularly as schools go back. So they're not able to do the community facilities, but I'll get you in touch with someone else who can support.
Thank you, Amanda. That's the end of the committee's questions. It's a throwaway comment I'm going to make to you all. When you are considering reviewing things, could you please consider the relatives? Because having been a relative who had a relative die, a very close family relative die during the COVID, the effect on the family, the effect upon the funeral, the effect of not visiting has been dramatic. And when you do review, I would ask that you look at the effect on families. I don't want an answer because I'll end up crying, Amanda, but certainly I would ask that you look at relatives. Mark, you're the non-committee member that's here, so over to you, Mark.
Chair, I noticed that Councillor Tucker has put on an RTS again. I don't know if you want to bring her back in, if it's something related to what you've just been discussing first.
Thank you for being so kind. Tanya?
Thank you, Chair. Thank you, Mark. It's just an addendum to the comment from Councillor Beattie about our community centres. It would be helpful, Amanda, if all members could have some information to share with our community centres, because I particularly have one that offers out of school club care for when the schools aren't around and there are children who need that care, so parents can work, and we're looking to get back into operation. So any information, advice, support that can be given would be very, very welcome. Thank you, Chair. I appreciate that.
No, thank you, Tanya. And thanks, Mark. Over to you, Mark.
Thanks, Chair. Thanks for the opportunity to join in with the debate and the discussion. I've got questions regarding two different paragraphs, and And to yourself, I hope it'd be possible to just go through one and get some answers and then maybe come back to the other one to avoid some confusion. The first one's just relating to the, it's actually like Owen earlier. I've had a lot of concerns regarding the hospital discharge figures, the paragraph 51 of the report, and I appreciate the sensitivities, but I think there are some further questions as well relating to this, and I do wonder whether all of the patients discharged from hospital since the date that we started to free up beds in hospitals are fully recognised in the figures, because testing wasn't actually taking place at the beginning of the pandemic when the government announced that we had to start freeing up beds. Those tests weren't available, so I'm wondering, following on from that, if I could ask the care partnership officers to what extent they feel that the discharge of what was hundreds of elderly hospital patients very early on directly into or back into, in some cases, care homes could have contributed in some way to us as a county having sadly one of the highest death rates in the country in terms of care home deaths. And then related to that, we've got 96 older people's homes, care and nursing homes in the county, and at least 58 of them have seen, sadly, COVID deaths, which is about 61%. So has any analysis been done yet to see if there's any coincidence between those care homes that were accepting patients from hospitals and those care homes which have seen deaths? And then if we could come back afterwards, Chair, on the other paragraph.
Yeah, certainly. Sue, I think you came straight in at the very beginning of Mark's comments. You'd like to come in, Sue?
I did. Mine's more just for clarity in terms of how we can produce the data from CDDFT. So we know every patient that's been admitted into a bed and then goes somewhere afterwards, so is discharged to a location. The way we've got the information for you is we've picked every single patient who's been discharged since March into a location that's a care home or a residential home in County Durham and Darlington. It's possible we also discharge wider, but that's how we've produced the information for you. So if a patient's come to, say, A&E but not been admitted into the hospital, so they've come with an ankle sprain or anything else but hasn't needed to be admitted, they're not discharged. So we won't have picked up those patients, just for clarity. So it's only the ones in County Durham and Darlington residents were, because we have a discharge address for everybody, we're confident that our numbers do pick up anyone going into those facilities, and discharges are for patients that have come in and essentially stayed in a hospital bed, not those that might have, say, attended an outpatient department. So we haven't given you any of those figures, just the ones that have been admitted into hospital, if that helps.
Thank you, Sue. I've got three people as well want to respond, Mark. I've got Sarah Burns, then I've got Lee, and then I've got Jane. So can we start with Sarah, and then we'll go straight through to Lee and then to Jane. Thank you, Sarah.
Thanks, Chair. So we are looking at all of those things. I think Amanda would echo my comments about coronavirus. It's a novel virus, and we've learnt as we've gone along about the impact and the issue of people being asymptomatic but carriers of the virus. We are looking at all discharges from hospital and comparing that to the patterns of infection within a care home, but we know that there are care homes who admitted no patients from hospital and still had an outbreak. So what it is very difficult to actually ascertain the source of an outbreak, because we know that there are care homes who haven't admitted anybody that still have infection. And even if a resident was admitted from hospital, trying to determine if they brought infection to the home instead of a member of staff or anybody else is virtually impossible for us to do. But I guess, to give you assurance, that is something that we're looking at in detail to understand that.
Thank you. Lee?
Thanks, John. I think Sarah in the mains probably stole my thunder there. I was just going to sort of add that from certainly my experience, and I can't say that I'm an expert at all in terms of the spread of such infection, but my sort of experience has been right at the very heart of this throughout, and from sort of understanding lots of scenarios, etc. It's clear that it's multifaceted for lots of reasons. I dare say if I was to kind of stick my neck out, we can probably never ever know the full reasons why this virus finds its way into any kind of environment, because there's just so many complex factors at stake here. So, you know, Sarah's rightly pointed out, you know, we've learned increasingly that, you know, asymptomatic people, possibly people employed within care homes, carrying the virus, not even knowing that they actually have it. Obviously, you've got to look at our socio-economic factors within Durham, the high prevalence of care homes in Durham, so many things that make this really extremely challenging. And obviously it's something which is playing on all of our minds throughout this period.
Thanks, Lee. And then, of course, we now have Jane.
Thank you, Chair, and thanks for the question, Mark. And I think Sarah and Lee have probably covered everything I was going to say, actually. But I think just a couple of points just to make. Across County Durham, we have got a very large number of care homes, but I think it's really important to recognise the really hard work that's gone in throughout all of those care homes. The staff have worked tirelessly, they've followed the guidance, and I think Lee's point around we may never know absolutely how things have spread. It's obviously a very challenging time for them, and I just wanted to kind of record thanks and recognition of the work that they've done, Chair, if that's okay.
Thank you, Jim. Mark, you've got a second question.
Yes, and actually that kind of flows through quite well, actually, because the other question I wanted to raise was in relation to paragraph 58 regarding care homes, and the council's provided significant financial assistance to our care homes throughout the pandemic from the beginning, and they've needed to sign new funding agreements as part of that. Communication has been really critically important throughout this period, not just obviously with the council departments and the NHS and other bodies, but critically also with elected members. And I'm just wondering if officers can confirm to us that cabinet members have been provided with the necessary information they need, and with copies of, for example, the funding agreements, which from the beginning were passed out to care and nursing homes, because obviously they had to agree to certain things in order to receive the funding that was coming through from the council and government. Back to the first agreement that was put out in April the 15th or roundabout. I'm just wondering if officers can confirm if cabinet members were receiving this documentation to view in advance of it being sent out to the care homes. And specifically to that very first contract that we agreed with, that we sent out to care homes back on the 15th of April, how many providers actually signed that first contract?
Well, clearly you've got Jane Robinson, Mark, wanting to reply, but I would also actually ask, unless Jane's going to do it, refer members, and that's what I was frantically looking at before, Mark, refer members to the attached letter that was sent out by Terry Collins to care partnerships and care homes. So there is a detailed letter attached to our papers. Jane?
Thank you, Chair. I think just a couple of points to flag, and I know we've previously had a conversation about this, Mark, but we've never required the care providers to sign any agreements, and I think there's been reflection this morning in terms of the guidance that we followed that's come nationally, and that's changed frequently throughout that process, and we've continued to follow that guidance. So payments have been made to providers regardless of them having to sign any kind of contractual agreement around that. The other point in terms of elected members is throughout the whole process, obviously we've kept Councillor Hovels, who I know was in committee this morning, updated in terms of the actions being taken. There's been regular briefings that have gone out to members. There's been regular briefings with Cabinet and with opposition leaders throughout that whole process. In terms of the wording of the actual contract addendum, which is what I think you're referring to, that's kind of normal commissioning practice in terms of that being an officer role to do that, and wouldn't necessarily have conversations with the lead member around that. But I think in terms of the general principles, in terms of following the guidance, that's been the stance that we've taken throughout, and the funding has been made available to providers regardless of that, as the guidance has changed to reflect that.
Chair, could I make just a very short...
That bit about the funding is referred to in the letter I was talking about, this part of the addendum, financial support. Of course you can come back, Mark.
Yeah, it's just a fundamental point that I believe that where you've got sensitive documentation in this kind of environment, in these kind of circumstances, being sent out to care home providers when they're dealing with so much, that where it's related to funding and agreements, and where there's sensitivities within those documents, I do feel it's important that our cabinet members, or at least the portfolio holder, does get sight of some of these, because some of the wording in some of the contracts that I've been sent by care home providers to read was quite sensitive, as I've raised in a previous meeting, and I do honestly believe that cabinet members should be seeing this before it goes out, in order to just give that glance over and to give that political viewpoint if perhaps there's something that's written which may be a bit too sensitive, or not written in quite the way which we might, as elected members, expect particular documents being sent out to providers. Thank you, Chair.
You've got a final response from Jane, I think, and then we'll move on. Jane?
Yeah, it was just to reiterate the point, Chair, in terms of following the government guidance and relevant members being updated as to that as it progressed throughout the process, Chair.
Okay, I think Mark's gone mute, which means he's not coming back. So thank you for that, and I think we've had a good discussion there this morning. Before he left, Rob Crute, the Chair of Review Scrutiny Management Board, sent an email to me asking that we add into one of the recommendations in, which I will do as we go down. So what we're not recommending to members is that we note the contents of the report. We acknowledge the work of the County Durham Care Partnership in response to COVID-19. We acknowledge the strength of relationship and partnership working in County Durham, which has been invaluable during the period. We recognise the outstanding efforts and response of all staff, volunteers and residents to COVID. We actually, in link with what's been said this morning, ask for regular review reports from all agencies into how they are responding to COVID and also to the scrutiny of COVID. The one that Rob's asked for, which we all agreed to, is that we get a regular report on the local outbreak management, the one that's going to health and wellbeing. And finally, the last two is we acknowledge the immense contribution local communities have made to the response and the cooperation of County Durham residents throughout this unprecedented situation, and that we acknowledge the contribution of the council's employees across the whole workforce, and then our strategic partners as how they've all made a response to this. And can we agree their recommendations? I'm getting nods of agreement. Thank you. So we now move on to what the next item 7, which is Stephen, will you come in now and bring in the refresh of the work programme?
Thank you, Chair. Yeah, the report before members this morning invites them to agree a work programme for the coming year in respect of the activity that falls within the remit of the Adults Wellbeing and Health Overview and Scrutiny Work Programme. Appendix 2 of the report sets out a number of key areas of activity that the committee has been undertaking both during this past year and which we also know will be coming forward in terms of both adult and health services as well as NHS providers and commissioners. A little bit of a health warning against that, Chair. Obviously, we are in a different scenario in terms of how we are undertaking business at present. Obviously, we are undertaking activity through our virtual committee meetings, and we are also proposing within the work programme to supplement that with bringing reports for members' comments and information outside of formal committees to members and get feedback that way. So it's a combination of both the formal meetings that we have through Microsoft Teams and supplementing that with circulating reports to members of the committee for information and comment. And in fact, we've already done exactly that with the recently published annual report that County Durham Health Watch produced over the last, I think it was 2 weeks ago. So, Chair, the work programme is there for members' consideration and approval, and I'll take any questions in respect of that. Thank you.
Owen, Councillor Temple.
Thank you, Chair. I apologise because I know I've already spoken quite a lot this morning, but this is actually within that kind of train, you might say, because recent days have shown a renewed spotlight on social care. We've had Sir Simon Stevens saying that we need to get it sorted, a plan within a year. We've had the Prime Minister in a bit of trouble over suggesting that perhaps procedures hadn't been followed, and that was at the root of things, and then a clarification this morning. And I do feel that this committee needs to be on the front foot in relation to this new emphasis on social care. I've already admitted this morning to my own dissatisfaction with myself that I've never really raised the need for us to talk with social care providers on this committee. And I say talk with them. I just would like us to amend the work programme. I appreciate, Stephen, the huge difficulty of how we're working now with remote working, because at one time I would have, I would imagine a small committee room and a task group meeting with care providers 1 week, meeting with the council officers another week. And I'm not sure that task groups are going to work in the new world in quite the same way as they have done. But I do think that somewhere on the programme we should have a specific and dedicated approach to this committee's oversight of how social care has fared in the first 6 months of this year, because we already know that occupancy from the report we've been given is down from 87 to 77%. So how they have fared through this crisis and how in the future we are going to make sure that the partnership is strong and we contribute to that as a committee. So I value the advice of all the other committee members on this, but do they feel that this is something we should have a dedicated spot for, rather than just it's there as part of the generality somewhere in our programme in the not too distant future? Could I perhaps ask that the committee consider that and yourself and see where it leads?
I've got no problems whatsoever with it. I think you're correct. Jane?
Thank you, Chair. It was just to make a point really in terms of the review in terms of social care nationally. Obviously that's been long awaited, and it was just, and I hope please committee don't take this the wrong way. I know you're very well aware in terms of social care, but making sure that any considerations not just around care home provision and social care is obviously much broader, and it would be really helpful probably for the committee to consider the broadest context of social care going forward. Clearly, obviously, the issues Councillor Temple's raised there in terms of the impact of COVID on the care sector, absolutely, but it's just broadening that out to the fullest extent in terms of social care, Chair.
You're fully right, Jane. I mean, there are a lot of companies out there with a lot of care workers that have consistently been going into people's homes and caring for people in the homes. Stephen, would you like to come in?
Thank you, Chair. Yeah, the work programme's here for members' consideration and comment. And more than happy to include and incorporate within the work programme an item around the suggestion made by Councillor Temple. Maybe we'll have some discussions with our senior officers and consider how best we can do that. It may well be that we have a dedicated session specifically set aside for social care, a sector-wide approach, Chair. But happy to incorporate that and discuss that with officers to ensure that that takes place.
Thank you, Stephen. I knew you would. Tanya, Councillor Tucker.
Thank you, Chair. Just very briefly, I agree. I think we do need to hear from that sector of our providers. From a previous incarnation, I'm aware that in County Durham there is a group, a committee as such, that has providers. They do talk to each other. They have meetings on a regular basis. Perhaps we could connect with that and make the request, and then they could decide amongst themselves who the best person is to talk on their behalf. It's just a suggestion. Thank you.
I'm not being funny, Tanya, but what's the name of the committee for Stephen?
Oh,
is it a care home committee?
The providers have their own group, local. Stephen,
No
I'll
doubt,
look it up and let you know what it is.
Thank you. I said general, probably not. So, thank you, Tanya. So, are we agreed with the work programme and the addition that Richard, you'd like to come in?
Yes, I certainly agree with it. It's just such a broad field. We need to sort of, like, how can I put it, focused. If the government is going to, and I suggest it'll probably be up at least 12 months, given that it's been many years in the brewing, all this, be making significant changes to the system. We don't necessarily want to spend a huge amount of time scrutinising a system that's going to change. And the second point I'd make is that a lot of communications that we get as ward members from care home providers are in fact about the money and the contractual issues, which are not necessarily stuff that we really have any, how can I put it, any jurisdiction over or interest in. So I would suggest it's a bit like all the work programme really. It's going to be so fluid. We are used to dealing with changes in the NHS at quite a slow pace with very lengthy consultations that take years to implement. I think there's been more change in the NHS in the sort of the last 4 months than the previous 4 years. We're going to have to be very fluid and very flexible. So I certainly think it's very important to look at care homes and social care generally in the context of COVID particularly. But I would just sort of counsel against getting too stuck into what is a huge subject area that is likely to change from above anyway. That's all I'm saying. But I support the suggestion of Councillor Temple, certainly. Thanks.
Thank you, Richard. Stephen, do you want to summarise on this topic?
Chair, I think the recommendations within the report, I would just put those to committee that we receive and comment, which we obviously have on the work programme, and to agree that and the flexibility it offers to respond to those emerging issues, with the proviso that we'll have a discussion around ensuring that the care sector is included and incorporated within that work programme moving forward, Chair.
Thank you. So can we agree what Stephen just said? Yeah, I'm getting nods. Okay, we've got any other business. Can we say thank you to all our colleagues and friends who've come and joined us? To the NHS, can we wish you a very, very happy 72nd birthday? I've looked at all of you and believe me, you're all there, bearing up very well. None of you look to be the age of 72, but congratulations and happy birthday to the NHS, and long may you be with us. Ladies and gentlemen, the rules are quite clear. We're about to now come off live and stop, but could people put off their microphones and make them mute, and we will be told by IT when we can disconnect. Thank you very much for today.
Thank you, Chair.